Welcome, everybody. Thanks for, we think it's the 15th year. We lost count, but we'll say it's the 15th year, and we'll do it again next year. We'll say it's the 15th year. I don't know where they got that photo. Here are your directors, Alexandra, Kat, and myself. I was very surprised when they took the picture. Thanks to our faculty. What a great group. Shruti, Diana, Justice, Jeremy, Danny, Dr. Martin, Anath, Rishi, and Christina. It was a great crew. We're going to learn a lot today. Here are our learning objectives. I'll let you read it on your own time. This is being partnered with a couple of different groups. We have essentially done this independently. There's CME credit for this. iVista is running the show on this. Thank you to our exhibitors who we couldn't do this without. Please, in the breaks, make sure you stop by the booths. They have some really great stuff, some educational stuff. One of the things we neglected to talk about during the panel was how to interact with pharma. This is one of the ways you can do it, is to meet some people here who are really, really friendly. If you'd like to get credit for it, use this QR code, and this will help you get credit for this. There's a pre-test and post-test and an evaluation that you'll need to do. I'll show you the QR code again at the end of the night if you don't get it here, so we'll make sure that everyone has an opportunity to claim their credits. All right, with that, let's get started. Take it away, Kat.
Awesome. And then just as a heads up, we're going to hold all questions until after all the talks. So at the end of the first session, just to kind of keep us moving along. So first up, we have one of our organizers, Emeriti, Rishi Singh, Emeriti, who's going to be talking to us about what's new in the GA pipeline. Thanks, Rishi.
All right, thanks for having me back, and I appreciate being here with you all. So I'm going to talk about what's new for our treatments in this area. We've obviously had 2 FDA-approved drugs here, my financial disclosures, and we're using them in practice, and we all know that there's limitations on them. So here are those 2 agents we have right now. Syfovre or pegcetacoplan or Izervay or avacid-capsid pegol. They're clearly different in where their mechanism of actions are. They're C3 inhibitors, C3 inhibition with Syfovre. Izervay has a C5 inhibition. The dosing schedules are different. We know that avacid-capsid pegol is given monthly for the first year, while pegcetacoplan, it can be given every other month. But we also know that they also differ in regards to their side effect profile in regards to intraocular inflammation. And one of the big drawbacks has been the majority of these things right now with our current therapies. So this is why we need better therapies, because we are stuck with bi-monthly or monthly treatment. We have 1 in 4,000 inflammation occurrences with the first injection. We talk about tissue preservation with the lack of vision preservation. Most of these drugs still lose vision despite our best efforts. And again, just some other kind of limitations of this overall. So let's talk about some of the emerging therapies and what we're looking at. And these are all the kind of pathways we're looking at, both neuroprotection, the reduction of toxic byproducts, suppression of inflammation, even stem cells and visual cyclomodulators are all the ones I'm going to focus on today. So when we look at this pathway, obviously we focus on the classical lectin and alternative complement pathway. The alternative complement pathway has been the place we found a lot of mutations for geographic atrophy. And so one of the areas that has been looked at has been the application of complement factor H. Complement factor H is the brake that prevents the downstream regulatory pathway for the C3 and C5 products. And therefore, if we increase the number of complement factor H proteins present, we may be able to prevent the dysfunction within this pathway that causes overreactivation of C3 and C5. 4DMT is looking at this transgene cassette approach, which uses an optimized complement factor 8 codon, which is encoded within this R100 capsid. And this is going to be studied in an upcoming phase clinical trial that will look at whether it can reduce the progression of geographic atrophy in those situations. There's another product called ABD-104 by Avicida. This affects both the complement pathway, which we just talked about focusing on complement factor H, but in addition also focus on these siglet proteins, which are essentially signs of overactivation of macrophages. This is sort of the signal that a macrophage is overactivated. So what this product does essentially is stops those overactive proteins and actually repolarizes the macrophages into a non-inflammatory state. So that can decrease all of the increased complement factor H, but also decrease all of the other cytokines that are downstream. And it has been studied in a phase 2 study in the past, and here's the results from that phase 2 study, which showed a dose-dependent decrease in geographic atrophy area. And on the right side was the most interesting of all, which is showing finally a functional potential improvement in visual acuity. You may wonder how you can get vision back in geographic atrophy, and the thought process here is working on the cells that are just beyond the area of geographic atrophy, those cells that are polarized, that are near death, but can somehow resurrect them and prevent them from functional or eventual anatomical death. And that's what we're looking at and sort of trying to determine if this will be the next kind of phase of the product that will help our patients see better. This is being studied in a current phase 2/3 clinical trial, which is already enrolled with 2 different doses of ABD-104, both given monthly and every 2 months, compared to acid-capted PEG, given monthly during the course of the study. So, and the primary rate endpoint of this study is an anatomical endpoint, which is the change in the area of GA over time. Another approach is looking at the inhibition of the MAC attack complex, and this is J&J's 1887 product, which is looking essentially as preventing this C5 to C9 membrane attack complex, which is at the end of the complement cascade. And you can see on the left side their phase 1 results, which showed a increase in the reduction of GA growth over the course of the study. Obviously, in the first month 6, you saw that still progression of patients with geographic atrophy, but as the product continues, essentially you see the reduction of growth over the course of the entirety of that study. Annexon is also looking at a classical complement inhibitor called Seq1Q. This is an antibody fragment which essentially will bind to its product in the classical pathway. And this was studied in the Archer phase 2 trial, which looked at either ANX007 given either monthly or bi-monthly compared to sham. And they found that essentially it did not prevent the GA lesion growth, but what it did affect was another endpoint, which we're also using for some of our geographic atrophy trials, which is the loss of the EZ zone, which is on the left, and the EZ attenuation, which is an EZ less than 20 microns of thickness. So essentially, you're preserving photoreceptors through this product by delivering this. And this was the endpoint that was seen. And also what was seen, you can see this a little bit more in detail, looking at its effect. It really affected the central 2 millimeters and 1.5 millimeters of the area of the fovea, which helped to preserve those photoreceptors within that area. In addition, it also reduced the number of patients who went on to having 15 letters of vision loss on the left and more preservation or stability of vision on the right. So this is, again, showing you that there could be potentially a functional endpoint gain with some of these products, and this is one in particular that's being studied right now in a phase 3 clinical trial. Gildaretinol, ALK001, is actually a deuterated vitamin A. And we know that vitamin A dimers accumulate and they cause active dysregulation of complement proteins. And they can be involved both in wet AMD, geographic atrophy, and Stargardt's disease. And this has been studied most in Stargardt disease up until recently, but there's also a geographic atrophy program that's emerging as well. Deuterated vitamin A prevents the cyclic effect of the photoreceptor cascade. It essentially prevents that, slows the visual cycle function within the eye. And in this case, they did find some moderate reductions in GA lesion growth, as you can see on the left side and within this phase 1 trial. On the right side, you see that there is also a preservation of visual acuity in these patient populations. Again, this is an oral agent, which is actually quite interesting. Even if it has a moderate effect, it may be beneficial over, obviously, placebo or nothing at all. So it actually is quite an interesting protein to look at, and it may be another pathway to consider. And etamopride is another product that's being studied within a recent clinical trial. This is a phase 2 study that's now going into phase 3. The RECLAIM study actually looked at these patients who had been given this etamopride. Etamopride is a protein that actually reduces mitochondrial oxidative stress and damage. And you can see that in these kind of animal models that you see given here, that when you have essentially conditions where oxidative stress and damage occur, the cristae within the mitochondria become enlarged, they actually get ballooned, and they actually can die off over time. So the potential here is that if you have mitochondrial overreactivity and this oxidative stress and damage, by giving etamopride, you might be able to reduce that over time. This has been studied in the RECLAIM 2 study, and actually Justice was part of this reading, and his reading center was part of this study, and you can see on the top right here in the placebo that there was essentially the progression of those patients both from photoreceptor loss, which was the blue, and the RPE loss as well. And on the bottom, you see the effect of the etamopride, which really reduced both photoreceptor and RPE loss. And in the middle, you see that attenuation again. The attenuation of the EZ zone was reduced as a result of getting this injection for those patients. And this is given subcutaneously in this patient population, which is also another interesting approach. And finally, probably the moonshot here is stem cells. And we've obviously heard a lot about patients getting intravitreal stem cells that, that can come out of clinics. Those aren't working, and those should not be given to any patient. But there's obviously lots of different ways of both transretinal, suprachoroidal. There's autologous versus allogenic. There's actually scaffolds, as you can see here, on the cover of Science and Translational Medicine, which is a scaffold that's given subretinally to, again, preserve or recalibrate the retinal foveal contour and actually give you back the area you've lost of the RPE cells. So potentially you have these other opportunities that may exist as well. These are some of those future targets that I just spoke about now. And just to end, the interesting thing about this slide is that if you look at the time period by which you might get these products, it's probably 2028 to 2029. So it's a really far time away, and we're going to hopefully have these products in our hands sooner than that if the studies can be enrolled and come to us. But that's a pretty far time away to see all of these different things, and hopefully we'll see the benefit of our patients for those. Thank you.
Thanks, Rishi, for that excellent talk. It dovetails really nicely into our next talk about not only about what treatments are going to be coming, but how do we treat patients with GA now. Christina Wang needs no introduction, but thank you so much for coming to join us at our summit. And Christina,
Thank you,
so
Kat.
much.
Thank you to the whole I team. It's really an honor to be back here. I remember being here as a fellow just, 2-3 years ago, something like that.
Just yesterday.
Can I get my slides up, please?
There, I just go forward. It's your
Oh,
next
okay,
one.
sorry,
It's
got it.
just a continuous.
Okay, perfect. So I think there's probably no other disease at this current time in the retina space that will draw a more wide array of opinions aside from GA when it comes to asking people when to initiate treatment. So a lot of discussion, and the TLDR, honestly, for this next 8 minutes, is that I don't have an answer for you, but I hope that you'll leave with some considerations as many of you venture out and take care of your own patients in the next year or two. These are my disclosures. Of note, I am a consultant for both Apellis as well as Iveric Bio Astellas, and for those of you who aren't familiar, Astellas acquired Iveric Bio in a nearly $6 billion deal in 2023, which is why you often see those companies listed together. Let me start off with a patient of mine. This is a real patient I took care of, 67-year-old healthy female, pretty prominent politician in Houston. And she first presented in 2017 with intermediate dry AMD, right? Something we see all the time. But I followed her very closely for the next 6 years. And so I want to share with you some images from both of her eyes to show you what happened. The year after I first met her, she came in with some vision changes, and you can see in 2018 she's converted to the exudative form. She was one of those home run textbook response patients. She dried up right away and was able to extend immediately out to 12 weeks on anti-VEGF. So really a home run there, and you can see she's maintained 20/25 vision throughout that 6-year period. All while this was happening, take a look at what's happening with her left eye. Also started with intermediate dry AMD, but year on year, you can see central GA increasing, and she lost pretty much a line of vision with every passing year. And unfortunately, we weren't able to do anything at that time. You can see the end date there is 2022. And this was one of those patients that really made me reconsider my response when patients would ask me, what's the better kind of macular degeneration to have? And I don't know how to answer that question anymore. But leading into this, as Rishi really beautifully summarized for us, we now have 2 FDA-approved complement inhibitors in our toolboxes for the treatment of geographic atrophy. And I'll draw your attention first to that bottom line, because I think that one thing that was really fascinating watching this all unfold was they had trials that were going on very much in parallel, and they also obviously launched within 6 months of each other. So the business development and the drug development aspect of this story is also, I think, really fascinating. But both of these are pegylated molecules. They are complement inhibitors. They act at different sites, pegcetacoplan at C3, avacincaptad at C5, a little bit further downstream. Rishi already covered the pivotal trials, which looked at these GA lesions that were between 1 and 7 disc areas. This one important difference to point out here is that pegcetacoplan took sort of all comers of GA lesions, whereas avacincaptad, those lesions had to be non-center point involving. Here are the main summary findings from the pivotal trials, and I think it's fair to say that there was a modest decrease in the GA lesion growth rate seen in these studies. OAKS was the statistically significant one that met the primary endpoint. Derby did not meet that primary outcome. But importantly, there was no difference in visual acuity or some of the secondary visual function endpoints, which is why I think it's been a little bit challenging. It's posed as one of those challenges for widespread adoption. Even though these 2 came out in 2023, we didn't all jump on the bandwagon. And one of the other aspects that made it a little bit less palatable in terms of starting treatment for patients was, of course, some of the safety issues that arose fairly soon after these came onto market. So these are just a couple of the adverse events that you'll hear about when people talk about complement inhibitors. There certainly is an increased rate of CNV development. There's no doubt about that with these complement inhibitors. You can see the rates there. A small percentage of patients in Derby and Oaks also developed NAION. All of those were discs at risk. So if you see somebody with a small cup to disc ratio, that should be taken into consideration when you're thinking about treatment. But the big one really is in that third row, which is intraocular inflammation. And I think the first thing to point out is that it's important to note that there were no cases of retinal vasculitis that were noted in the pivotal studies for either of these programs. It wasn't until very shortly after launch, actually, with pegcetacoplan, that there were 14 eyes that were reported to the ASRS REST committee with retinal vasculitis and some with occlusive retinal vasculitis. All those cases occurred after the first injection, although that's not universally true with all the cases that have been reported since then. As the denominator of injections of pegcetacoplan began to grow, we've seen that rate come down. There's been some retrospective cohort studies that have found that rate to be 0.1%. Apellis quotes a 1 in 4,000 risk of IOI per injection, but we're all sort of exploring this area still. And then lastly, I'll just briefly mention there were a handful of cases of culture-positive endophthalmitis. And so really going back to the topic of the talk, when do we decide to treat these types of patients? And again, I told you, I don't really have an answer for you. We have not really become sophisticated enough yet in terms of risk stratification and patient selection. But we've got really smart people on the job, like Justice Ehlers, who's working along with Vasada, a lot of other people in our field looking at developing AI algorithms to really better risk stratify these patients. In the meantime, though, what should we do now? This is my opinion. These are the factors that I consider in this particular order. So I look for things like who's at risk for fast progression. And we know that there's a lot of different factors that are associated with that, right? Larger baseline lesion size, extrafoveal lesions, multifocality are all associated with more rapid progression. Even things like specific FAF patterns, like the banded or diffuse trickling patterns on FAF, may indicate that a patient is likely to progress faster. You'll notice a really odd one, second on my list, is patient motivation. Never have I used shared decision-making more than with this disease. And it's so odd because when you consider, its counterpart, wet macular degeneration, there's no thought. It's a kind of a binary decision. If they have fluid, we treat, right? And that's just not the case when it comes to GA. It's important that patients know what to expect and are committed to the long haul because they're going to be receiving injections indefinitely for a very, very long time. Monocular status and visual acuity are really plus-minus things, right? If you think about it, if you have a monocular patient who's 20/20, that's the best time to really go in and do something to prevent worsening. At the same time, those are also the scariest types of patients to start these types of treatments, just in case they have the adverse events that we see are a low but real risk. And so those are plus-minus things that you want to factor in. Other questions to ask, is this classic GA in terms of the pure definition in dry macular, or is this macular atrophy in wet macular, which is being used in the real world for this indication, but was not studied in the pivotal trials? And finally, age and life expectancy. So those are kind of the considerations that I think about. But even if you decide to treat somebody, I think there's a lot of unknowns in this space. We're very much at the infancy still. Things like drug selection, right? We've seen a couple of those MAKE analysis, which I don't think are particularly insightful, right? We haven't had a head-to-head between these two drugs, so we really can't compare apples to apples. Laterality selection, do you start with the better seeing eye, the worse seeing eye? Do you dare to treat both eyes at the same time? What about the timing of intervention, right? Think about the patient I started off with. Where would you have intervened in that 6-year time frame? Treatment schedule. So avacincaptad is only on label to be used monthly at this point, whereas pegcetacoplan, we can use it monthly or every other month. What are we doing? Like, what's the endpoint when we monitor these patients, right? What types of imaging should we be getting? Should you look at the patient each time that they come in? And finally, management of concurrent CNVM, which we know does develop in patients. My very first patient that I treated with pegcetacoplan, you can see to the right, after 3 injections, began to have these intraretinal fluid cysts that developed and is now also receiving anti-VEGF as well. So in summary, 5 takeaways based on the trial data. Treating earlier before they lose vision, of course, is ideal, but of course there might be patients out of that window that are still good candidates. Patient expectations are so important. You got to level set those expectations and remind them that the priority here is to slow down the disease. That takes a little bit of a mental switch for a lot of people, including us. And if you do proceed with treatment, make sure you pay attention to things like IOI, CNVM, and of course IOP, because remember we're injecting a slightly higher volume than we normally do with 0.1 cc's per injection. Thanks so much, guys.
Thank you. I think that was a really beautiful talk about a complex space. One of the things that I think you highlighted really nicely is how imaging can really help to guide sort of which patients are going to get worse. And so that segues into our next talk by Justice Saylors about imaging biomarkers for AMD.
Thanks so much, Kat. Thank you, everybody, for being here this evening. It's great to have the opportunity to talk here. These are my financial disclosures. I do serve as a consultant for multiple dry AMD companies. So as we heard from Rishi as well as from Christina, we're really in a next frontier for dry AMD therapeutics. We have new approvals, at least here in the US, and there's an expanding focus on additional opportunities and therapeutics that are coming our way. But one of our biggest challenges, as we just heard, is who do we treat and who do we actually put in clinical trials? Well, we know OCT has really transformed the landscape of the way we manage retina patients. And one of our questions really is what defines progression? Is it progression to GA? Is it growth of GA? Is it easy loss? Is it hypertransmission? And multiple groups have shown that SD-OCT has critical features that help us understand who's who in terms of that risk. That includes things like drusen volume, hyperreflective foci, reticular pseudodrusen. All of these things can help identify those patients who are at greatest risk. When we think about this biomarker sequence, one of the things we really want to know as we look at new therapeutics and new MOAs is when should we be intervening? We know with dry AMD we start with drusen, perhaps easy loss is next, hyperreflective foci after that, hypertransmission, and then ultimately iRORA and CRORA. What I'm going to focus on today is some of the new next generation biomarkers that are being looked at even as primary endpoints that are now approvable by the FDA. So I'm going to start with ellipsoid zone integrity and quantifying this. And why do we care about this? Well, multiple studies have shown in different fashions that this is linked to visual function in numerous different retinal diseases. And our biggest challenge was we didn't have a way to look at this across the macular cube in a way that could be scaled and reliably done in a clinical trial format, but that's now really recently changed. And a lot of that's due to machine learning technology and our ability to utilize this in large scale. So can we apply this to AMD? Well, there's multiple concerns that have been raised of these challenges, things like the complexity of drusen anatomy, the impact of directionality on the image and what it may mean for ellipsoid zone measurements, as well as what is that absence over drusen? Do we care? Is it just an optical artifact, or is it actually a pathologic significance, and it matters for our patients and how they experience the disease? So how do you get to reading center level reproducibility and feasibility? Well, multiple groups now are doing this across the globe, which is really exciting. For us at the Cleveland Clinic, it was really developing a multi-model integrated system that looked at different features from the ellipsoid zone at a line level, but also looking at things like hypertransmission and how that impacts whether or not we can measure things like geographic atrophy on OCT. We want to be able to measure this across multiple devices, not just on one device, but to be able to scale this to multiple different devices across the world. Ideally, especially from a regulatory side, we need readers to be able to interpret this, and it needs to be objective and not just a black box output, because that's really not allowed at this point from a regulatory side. So when we look at this, I don't know if my battery just died. I might need that. Was 10 seconds back. So when we look at the way we measure this in terms of ellipsoid zone integrity, one of the questions is, what are you measuring? For us, we're measuring in a couple of different ways. Really, this is looking at outer segment thickness, so the distance between the ellipsoid zone and the RPE. And total loss of that measurement is what's been determined by the FDA to be approvable, looking at this in dry AMD. Partial, as we heard from Rishi, of what was looked at in the Annexon data is looking at the 20 micron threshold and what that may mean in terms of earlier damage that we can see in the disease. So reflectivity is another measure, and this looks at the overall intensity or the brightness, and this has also been shown to be important in multiple different diseases. Here we look at this and we have to normalize that. In our group, we use the RPE. Max Fau and Frank Holtz have done some great work looking at this in MacuStar, and it used actually the ELM as the normalization band to be able to look at this across different scans. So can we do this reproducibly and consistently? Well, we actually went back and asked our team to do this fully manually, which is brutal. This took 4 months of 40-hour work weeks to actually go through this, and luckily nobody quit. But we wanted to be able to look at, could human to humans actually do this in a reliable way, but then can we compare it with an automated assessment, but then most importantly with a semi-automated deployment. And we see, again, really great consistency here across the board in dry AMD. But most important, does this matter from a pathologic standpoint? When we look for rapid progressors, so those patients who Christina alluded to that we want to treat, We have data now from multiple different trials. This is from the Derby and Oaks trial, and this was work done by Ursula Schmidt-Erfurth, looking at this for ellipsoid zone loss and looking at quartiles of those eyes that had the greatest amount of ellipsoid zone loss outside the area of geographic atrophy. And you can see here down in the bottom right, those eyes that have the greatest amount of photoreceptor loss or EZ loss excess are the ones that grow the fastest. So if we can identify those patients, they were also the ones that seem to have the most pronounced response to treatment. This is data that Kat presented last year at ASRS showing that from the GATHER studies, essentially it mirrors it in the identical way, and that is that the more EZ loss you have outside the area of the GA lesion, these are the eyes that grow the fastest, and that's really critical in terms of who you may want to look at. Well, what if we want to know who are the eyes that are going to actually grow from a total EZ loss standpoint? This was data from the RECLAIM-2 study. It actually looked at partial EZ attenuation based on quartiles. And if you look at the lowest quartile, it hardly changes at all. But when you look at the highest quartile, you see this dramatic increase in total EZ loss in the sham group, and even a greater reduction in total EZ progression in the elamipretide group here of 63%. What about intermediate AMD? Well, one of the big questions, and this is a very controversial area right now in our field, is are all drusen created equal? And at least from my perspective, we know from multiple groups that drusen substructure and drusen features are clearly linked to what we see in terms of progression risk to GA. Well, that may play out in how it affects the photoreceptors and their overall progression risk. So we see here the drusen map in the second column, relatively large amount of drusen there in green. The ellipsoid zone integrity map is pretty much all green, which says the ellipsoid zone is actually pretty healthy. 2 years later, there's really not much else happening there. A little more drusen, a little bit of impact on the EZ. We see here a similar amount of drusen at baseline with a widely different change in ellipsoid zone status here. And at year 2, we actually see GA development as well as greater increase in ellipsoid zone. And this is the patient in an intermediate AMD trial I'd want to have and not the first one. So what about functional signal? Again, this is something that we're actively looking at. This is some preliminary work that was done based on a small data set that's now been validated in a much larger data set showing that those eyes that have more central subfield EZ loss and even more on the central 2 millimeter, those are the eyes that have worse vision compared to the eyes that have that preservation. What about other biomarkers? Well, quantitative hypertransmission is also something that's been looked at carefully, as well as hyperreflective foci. Phil Rosenfeld and Ricky Wong have done a lot of work in this area, showing that this has a very high risk for progression to GA over a relatively short period of time. This can be measured both with a slab approach, or even now we've been able to look at it using the entire OCT. And this may be a really important opportunity in intermediate AMD for progression to GA. Lastly, hyperreflective foci has now been a very well-established biomarker for progression, but it's not something that's like to be FDA approvable looking at it from the regulatory status. But again, one of the very first data sets to look at was actually the AREDS A2A and work that Cindy Toth and others have done in this space to show the importance of this. And so you can imagine designing a clinical trial, integrating these biomarkers to put the right patients into the trial to be able to identify in a relatively slow-moving disease who are the ones that are going to move fast. This is a disease progression example here of a patient showing the hypertransmission overlay, the GA there in pink in the third column, and then the ellipsoid zone integrity map. And you see the various stages of where those biomarkers are at sort of the leading edge of the disease. And then lastly, I'm just going to speak briefly about nomenclature and terminology. This is something that is rapidly evolving. It used to be the ISOS, then turned into the EZ. The measurement process is variable, but that doesn't mean that one is totally right and one is totally wrong. These may have values in different diseases and different forms in the way that we manage it, and it's important to not close the door. The MOA that we're looking at for the drug may actually matter in terms of the way we want to measure it. And for example, cellular therapies that actually are bringing it back versus drugs that are slowing it down may be critically important. We look at it in uveitis, it's different than how we look at it in inherited retinal diseases. And regardless of the terminology, when we look at this, the directionality is all in the same way, and that is that more EZ loss tends to be worse disease. And we really don't want to get too caught up in the controversy around this to confuse our regulatory authorities of the validity, the importance of this as a biomarker. So lastly, there's just a number of biomarkers that we really have in this disease. What we have to do is be able to leverage this as clinicians to be able to treat the right patients, but also get the right patients into clinical trials. Again, I want to thank my team, and thanks for the opportunity again to be here.
Thanks, Justice, for that very comprehensive look at imaging in AMD. So we're going to change gears a little bit away from geographic atrophy. Danny Mamo, our colleague, is going to be presenting on real-world experience with aflibercept 8 milligrams.
Thank you, Kat, and thanks for everyone for
And
spending
there's
your...
some seats here in the middle and some that, come and hang out with us.
So I'm going to talk a real-world experience with aflibercept 8 milligrams in AMD and DME. Here are my disclosures, none are relevant. So high dose of aflibercept 8 milligrams Eylea HD was FDA approved in August of 2023. It delivers a higher molar dose than aflibercept 2 milligrams, allowing for sustained disease control of neovascular AMD as well as DME. Now, the FDA recommended schedule we'll talk about today is 3 initial monthly doses, followed by intervals of at least 8 weeks or plus or minus 1 week apart. So really 7 weeks or more after your first 3 initial monthly doses. So PULSAR, we all know, is a phase 3 randomized double-masked study, and it had 3 arms. Aflibercept 2 milligrams every 8 weeks after 3 initial monthly injections, aflibercept 8 milligrams every 12 weeks after 3 initial monthly injections, and then also aflibercept 8 weeks in a Q16 arm. And they looked through week 96, and there was a 1-year extension through week 156, and their primary endpoint was mean change in BCVA. It was a non-inferiority study. So if we look at the dosing schedule, as we see here in the DRM criteria, notably, interval shortening was if you had a greater than 5-letter loss in BCVA compared to week 12 due to persistent or worsening neovascular AMD, and a greater than 25 micron increase in CRT, or new foveal neovascularization, or a new foveal hemorrhage. Notably, the minimum assigned dosing interval was Q8 weeks. So here we see at 1 year and year 2, great durability. We see that the 8 milligram Q12 and 8 milligram Q16 arms had similar visions to the 2 milligram Q8 week arms, allowing for vision maintenance with a longer dosing schedule. When we look at central subfield thickness, as we assume should be correlated with the vision, we see at 1 year and 2 years, we see a similar a decrease in CST between these 3 arms. Now, if we look at through year 2 at the dosing interval, if we look at the last assigned dose, a fair amount of patients made it past Q12. If we look at the bottom gray part, 11 to 13% of patients could not really get past a Q8 interval. And if you look at the pulsar extension through week 156, if you look at the gray bars up there, the number rose a little bit to 22%, but still greater than about 4 in 5 patients were able to get out to Q12 or more. So in our clinic, we were seeing really home run results with aflibercept 8 milligrams. We were also seeing some patients that were being transitioned from Avast, bevacizumab, faricimab, aflibercept 2 milligrams, that also maybe weren't able to totally dry up. So we wanted to see what % of our patients were able to get past that 7-week mark. You'll be able to ask your difficult questions, not to me, but to Suraj Bala on Tuesday. So we wanted to assess the short-term outcomes of neovascular AMD patients with our initial outcomes with our patients. So this was a single-center, non-comparative retrospective study, and it was all patients with neovascular AMD that received greater or equal to 3 intravitreal aflibercept 8 milligrams injections with greater than 1 subsequent follow-up at our eye institute. Notably, look at the date from August 2023 to October 2024. So we know that usually we're using some of these newer medications on maybe some previously treated patients, so something to note with this study. The primary endpoint was the proportion of patients able to sustain treatment interval of 7 weeks or longer after 3 initial injections. We looked at OCT data, vision, IOP, and safety. Successes were defined as eyes free of macular fluid at the final follow-up visit, and that received the 4th and 5th high dose of aflibercept at an interval of greater or equal to 7 weeks. Eyes were in failure if they were switched to another anti-VEGF agent or received a 4th or 5th high dose of aflibercept at an interval less than 7 weeks, or they exhibited persistent macular fluid at final follow-up visit. Most people tend to treat to dry for AMD. So there were 219 total eyes from 184 patients with a mean age of 79.6. Most notably, only 4.6% were treatment naive, so this is a majority previously treated population. Average number of prior injections was a mean of 22.6 injections. You see here that patients mostly had received aflibercept 2 milligrams previously, with some patients also receiving faricimab, bevacizumab, and ranibizumab. We had a mean follow-up time of 23 weeks. So key results, the mean injection interval increased significantly from 5.8 weeks to 7.4 weeks. 21.5% of eyes achieved a dry macula at greater or equal to 7-week interval after the 3 loading doses. And successful eyes had fewer previous injections and lower baseline CST. So it seemed that the eyes that were able to get to 7 weeks or more had a little bit less of CST. So the eyes that had higher CST, more difficult to treat patients, weren't able to get completely dry after 7 weeks. Here we see that you see in these difficult to treat, previously treated patients, you see a decrease in the amount of intraretinal fluid and subretinal fluid after switching to aflibercept 8 milligrams. We see a decrease in CST, we see a maintenance of BCVA, and we also see a slight decrease in pigment epithelial detachment height as well. Of patients that were switched to another therapy, 11%, the main reason was because of the treatment interval. Rare reasons were also insurance and cost and patient preference. But I want to note the red areas here. So even in the patients that were switched, many of them had a decrease in IRF and SRF and also PED height. So it seems there was an added benefit to the medication, but maybe not enough for these patients to be able to have them be injected less frequently than 7 weeks. We had no elevated IOP, no cases of retinal vascular adverse events, and no vasculitis. Here are examples of patients previously treated with aflibercept 2 milligrams and faricimab showing resolution of fluid with aflibercept 8 milligrams. So key takeaways is that there were stable BCVA and significant reductions in macular fluid during the follow-up period. 78.5% of mostly previously treated patients in this series had persistent macular fluid at 7 weeks. Findings suggest that high-dose aflibercept preserves function and improves anatomy, though real-world challenges may limit interval extension in chronic, more difficult-to-treat cases. So if we switch to the PHOTON study, they had a similar 3 arms. Also, the minimum interval was Q8 weeks. They had a slightly different DRM criteria because in DME we can tolerate a little bit more of fluid. If you look at the mean change of central retinal thickness, if we look at the Q8 arm compared to the Q12 and Q16 arms for aflibercept 8 milligrams, we see that there's not a significant difference between the mean change in CRT, so there's nice durability here. If we look at vision, despite the maybe increase in CST with the 8 milligram Q16 group, we see at the end of the day, vision was not significantly different between these 3 arms, proving some durability here. And if we look at the patients in PHOTON, this is a nice analysis that they did. If you look at the percent of patients that really couldn't get past Q8, they looked at how many needed additional interval shorting through week 48. And you see that there's a small percentage here, 1.7% of patients in the Q12 group, 8 milligram Q12 group, 1.3% in the 8 milligram Q16 group, and 1.5% of patients in all 8 milligram groups. So we wanted to look at the same thing for DME. And here you can ask your tough questions to Gabriel. He'll be presenting this Monday. So this is a similar study. We wanted to look at our outcomes. We didn't look at having fluid be completely dry at 7 weeks because this is DME and not AMD. But we still wanted to look at the proportion of patients able to sustain a treatment interval of 7 weeks or longer after the initial 3 loading doses. We had 100 eyes from 67 patients, and just like the AMD, most eyes were previously treated. So SRF and IRF remained stable, with 90% of the eyes with persistent IRF at last follow-up. Visual acuity remained stable, CST decreased significantly, and 32% of eyes did not adhere to the 7-week treatment interval after 3 initial doses, so about 70% were able to. Eyes treated greater than 7 weeks had a lower baseline central CST, just like an AMD, and 18% of eyes were switched to another anti-VEGF agent. All were due to the inability to extend. Here we see the graphs. We see that best visual acuity was maintained, and if we look at the bottom right picture here, for the groups that were unable to get greater than 7 weeks, we see that they had a higher initial central subfield thickness, suggested that these were very difficult to treat patients that probably need a higher VEGF load or maybe a different mechanism. There were no major adverse events. Key takeaways that aflibercept 8 milligrams demonstrated stable BCVA and significant CST reduction during the follow-up in these previously treated patients. 32% of patients in this cohort did not reach the greater than 7-week recommended FDA interval. Aflibercept 8 milligrams preserves function and improves anatomy, though real-world challenges may limit interval extension. And finally, in previously treated patients with persistent fluid, a more flexible dosing label and/or treatments targeting different mechanisms is an area of need. Thank you.
Thanks so much for that excellent talk, Danny. It's really helpful to get real-world evidence since we often start treating on patients who have already got injections. Our next speaker is Diana Doe, who needs no introduction, coming to us from Stanford. Thank you so much. Who's going to be talking to us about faricimab.
Thank you so much. Thanks again for inviting me to this great session. And I want to talk about real-world data and faricimab and what can we learn from this. These are my disclosures. You know, there is an explosion in real-world data. If you look up how many studies are being presented or being published, thousands every year. And why is that? Well, we know that big data in medicine and medical research is not new. We've had epidemiological studies for years now, which have gathered big data. But really, over the past decade, the explosion in electronic health records has helped us aggregate the data more easily. And that's why these big data studies are so popular. Let me ask Sunil, you're an expert at asking us questions. What do you think about all these big data studies? Do you think they're helpful, or do you think we should have some reservations with them?
They're helpful, and I have reservations.
Okay, good. Correct answer. Well, let's take a look at why we should have some reservations when we analyze these big data studies. We know large sample sizes are more likely to find statistically significant associations with small effect sizes that may not be actually clinically relevant. Big data sets are also observational. Analysis do not actually detect associations, and they do not imply causation. And big data does not stand alone. We have to use our medical expertise to interpret it in the broad context of all the medical data that is available. So let's see where big data can be applied. And my charge was to look at the faricimab data, and I asked my colleague, Dr. Borkar, who has presented it, to share me some of her data from the IRIS studies. So they conducted a large review of the IRIS database, looking at the use of faricimab in the real world. So let's critically look at this study and see what we could learn about it, and are there any limitations. So you know the IRIS study is a huge database from academic ophthalmologists throughout the United States. There is some abnormality with the font here from the transfer from the Mac, but what it says is that they actually, if anybody can decipher this, they win the prize. Anybody? Oh, okay. What it shows us is they actually looked for patients who had the known diagnosis of neovascular AMD or diabetic macular edema, and then were treated with faricimab for at least a 1-year period. They also included patients who had 1 year prior of, before initiation of treatment to see what their pattern was. And then they wanted to infer from this data what we could find. So let's see. We know that this first started off with hundreds and thousands of patients. But when they looked at these inclusion criteria, then the numbers decreased slightly. But we still ended up with over 34,000 eyes that were previously treated with wet AMD, and over nearly 10,000 patients previously treated with diabetic macular edema. We also had treatment-naive patients as well. So they followed these patients for 12 months to see what happened with their vision and anatomic changes. So first, let's look at neovascular AMD, and let's look at vision outcomes. So we look at the first graph on the left. You know, the horizontal line is the number of faricimab injections, and the vertical line is the change in their Snellen visual acuity. So this was not best corrected visual acuity. And what we see is, yes, it seems like there is a trend. When you give more anti-VEGF and Ang2 inhibition with faricimab, patients on average that were treatment naive gained vision. What happens to previously treated eyes? That's the graph on the right. We see a similar trend where there is a trend towards improving vision, but some patients, they could not improve vision, maybe because they had scar, fibrosis, other things that might have limited their vision outcomes despite 7 treatments with faricimab. What about anatomy? So, OCT and retinal thickness is a big imaging biomarker that might trigger retreatment. Let's see what happens in treatment-naive and prior treated eyes. So again, Sunil, look at this data. Do you think it's convincing that faricimab, has a beneficial effect in these patients?
I think it's helpful to see what's happened with others, but it doesn't necessarily inform me what's happening with my patient.
Yes, well, as you said, this gives us some good associations, but it doesn't really tell us the whole story about the patient, because it's what the data we put in as physicians to the database is what the data we get out. And I know in a lot of my electronic health records, I don't always write down the central subfield thickness. I use like qualitative instead of quantitative measures, saying edema, no edema, fluid, no fluid. But this shows us that there is a trend that more faricimab injections results in a thinner retina with removal of excess retinal fluid, whether it's treatment naive or previously treated eyes. What about diabetic macular edema? Same type of analysis. We looked at treatment naive and previously treated eyes, and there is that association with more faricimab injections. Patients were gaining more vision over time in the treatment naive group. How about durability? Does it show us anything about durability of these medicines? Because faricimab and even aflibercept 8 milligrams, one of the main enthusiastic points about these new medicines was the potential for fewer injections, better disease control over time. Let's see what happens in the IRIS database. Well, when we look at the mean number of injections over 12 months of faricimab treatment, and we look at treatment-naive eyes, we can see that in the beginning, the first 6 months, there are more injections, maybe on average 3.7 injections, represented by the blue bar. But in months 6 through 12, the number of injections decreases. It's only 2.1. This might suggest increased durability, or it might suggest the patient did not come back for injections. It might suggest other factors that we do not know about in the medical record. What about safety? When we look at these huge registries, it is helpful because sometimes you can detect rare safety signals that would not have been picked up in the clinical trials. When we look at rates of intraocular inflammation or endophthalmitis, they're very low, consistent with what we saw in phase 3 clinical trials. So what can we take from these big data studies? First, it shows us a little bit about how we're using a medicine in clinical trials. It gives us some associations, but it does not give us the cause-effect type of answer. But we see that these patients who are receiving faricimab in the IRIS database, they are gaining vision, especially if they're treatment naive, and the retinal thickness is decreasing. But we recognize with any big data study, there are limitations. The data is limited to what we put in. The more we put in, the more we can get out. We have no standardized measurements of why the patients were treated or not treated. We don't know that rationale because everyone was using their own treatment regimen. And it does not necessarily reflect future treatment patterns. So in summary, real-world data is very stimulating. It's great to see this information, but as clinician scientists, we should be wary of any information we're given and analyze it critically with all the information we have. Thank you.
That was such a great talk. Thank you so much. So our next up, we have a Cole Retina alumni, Jeremy, who's going to be talking to us about emergent therapies for neovascular AMD and diabetic retinopathy outside of injections.
All right. Thank you for the opportunity to speak. You don't have my slides yet.
Yeah,
And just go forward.
Just go forward.
It's just one guy.
There we go. My subject was a little bit dry, so first my disclosures, none of which are relevant. I felt like it was a little bit dry, so I used Gemini to create doppelgangers of some of our esteemed colleagues up here. So please pay attention. I had a lot of fun making the prompts.
You spent more time on this than the talk.
Absolutely. And I hope you will enjoy their outcomes. So we'll talk about a few things, mostly gene therapy, steroids, repurposing drugs, and novel therapies. So the first one is RGX-314, which is an AAV8 vector that makes a ranibizumab-like fragment. This is a subretinal surgery where they first started with phase 1-2 studies looking at 5 doses. And in the highest 3 doses, which I show at the bottom there, they were able to detect the protein and were seeing some signal for reduction in the anti-VEGF burden. And this is a mouse retina. Do I have a pointer, maybe? No. Okay, in the mouse retina, where it says merge is the area of the subretinal space, and in green are the macrophages. So this is a subretinal surgery putting an AAV vector in basically a space fairly devoid of the immune system. So there's less issues with inflammation compared to some of the other spaces. And so they're now moving to phase 3, where they're enrolling with 2 dosing regimens. Notice how they're kind of more in the dose 3 to dose 4, trying to reduce any inflammation-related issues. They also have a formulation that's put into the suprachoroidal space. Notice the doses in the phase 2 studies are all greater than the doses used in the subretinal surgery trials. They did get nice reductions in anti-VEGF burden, but inflammation's an issue. So this is a choroid from my lab where the macrophages are in magenta. So the choroid is just chock full of antigen-presenting cells. So you put a virus in there, and it's not surprising that you're getting issues with inflammation. The third space here for gene therapy is a AAV7-based vector that makes a aflibercept-like compound. In the phase 1 studies, they're using doses that are a little bit more similar to the suprachoroidal than the subretinal surgery. And you can see that there's sort of a dose-dependent both increase in inflammation as well as increase in effectivity. And now they've moved to phase 2 studies where they're using doses that are actually even below the phase 1 doses and doing a little bit better with inflammation. And this is the surface of the mouse retina where the vasculature is in blue. And in the white arrows are perivascular macrophages, and in orange are hyalocytes, which are vitromacrophages that express MHC2. So there are macrophages present that are going to be able to present the antigens for inflammation, but the density is far less than the choroid. So the inflammation is sort of in between. And if you couldn't figure out who that was supposed to be. Next up, we have subcutaneous drugs. This is actually now named since I made the slides. This is basically sunitinib in a nanotechnology formulation that's able to be given subcutaneously. So sunitinib is a VEGF receptor tyrosine kinase inhibitor, and its main 2 IC50s for VEGF receptor 2 and PDGF receptor beta are in the nanomolar range. They looked at phase 1 studies initially at about 0.25 to 2 milligrams per kilogram. On the top is their data looking at CNV area. So the middle 2 bars of the 6 are the subcutaneous. And you can see a dose-dependent effect that's basically on par or better than aflibercept, which they give at 40 micrograms. Below is our lab's data, which I thought was fun for comparison. So we get about a 50% effect similar to what they're getting. And so this seems like maybe it can do a little bit better. And so now they've moved into sort of a phase 1/2 trial looking at wet AMD and DME. And they're looking initially at a single dose, looking at different ranges with a 12-week outcome. And then they're going to follow that up with multiple dosing every 2 to 4 weeks in combination with some sort of aflibercept loading dose that wasn't really entirely clear on clinicaltrials.gov with a 40-week endpoint. But subcutaneous, I think, a lot of our patients would be pretty happy about that. If you couldn't figure that one out. With the crowd.
I like my crown.
It looked like you're ejecting that guy's head. So next are eye drops. These are similar receptor tyrosine kinase inhibitors. I'm not going to cover the 2 on the left because they're so early, other than to say that multiple exist. The one in the middle, this KHK4951, is recruiting internationally. It's inhibiting VEGF receptor 1, 2, and 3. 1's kind of like a decoy, but why not, I guess. 3 is more lymphangiogenesis, and some people think it's an escape mechanism. Sample size is fairly big, and they're comparing it at 3 different doses with aflibercept. Their primary outcomes are pretty strange with a loss of 15 letters. And their secondary outcome looks like they're looking at a number of injections, so either they're doing a PRN or some sort of treat and extend protocol and OCT features. Additionally, there are eye drops in the DME space, more in the steroid space. So basically, this is a dexamethasone eye drop. And they've done Diamond, sort of a stage 1, and then stage 2 and stage 3. So this is data from their Diamond 1 trial, where they see a reduction, or an improvement, in best corrected visual acuity with the eye drop alone, which, the improvements of 7 letters compared to our 10 to 15 letter anti-VEGF curve is not as good, but remember it's an eye drop, and I think a lot of our patients who are injection averse would be interested. And similarly with the secondary endpoint at 12 weeks is about similar, and they get reductions in SD-OCT. And this was supposed to be you, but it looks more like you plus Shackett.
Wow, I don't trust your AI program at all. I mean,
I know.
No, the
But
hair,
the way
the
it looks
hair.
like both of them, I just love that.
Sunil, that's your hair.
man, I'm screwed in the future, man. That's a terrible look.
So next up is fenofibrate, which is being looked at by DRCR. So Dan, you can decrease your talk time from 45 minutes a little bit now. This is a PPAR alpha activator. It was first found in the field trial, which is a not an ophthalmology trial, but an entire diabetes trial. And one of their tertiary outcomes was retinal laser for PDR and macular edema, and that endpoint was reduced. It's recently been replicated in an ophthalmology-specific trial in Scotland, where they enrolled patients with mild NPDR without DME, and then looked at their outcomes of progression to moderate to severe maculopathy, PDR, or need for treatment, and saw about a 25 to 30% risk reduction. And now this is recruiting in the United States and hopefully ending recruiting at the end of this year. Lastly, another oral drug for DR is this APX330. This is an inhibitor of REF1 or AP1, which is downstream targets. It's like a redox sensor in the cell, are NF-kappa beta, STAT3, and HIF1 alpha. So it's a combination inflammation angiogenesis inhibitor, which makes sense since anti-VEGF and steroids work. And these are the results of the Zeta-1 trial compared to placebo. They missed their primary endpoint of a two-step improvement, but they did see a reduction in three-step worsening or new onset PDR. So they are doing a phase 3 and changing the primary outcome to a three-step worsening. And that's how that one turned out.
These are awful, man. These are terrible.
I had a lot of fun, okay? Thank you.
I have to say, I'm really happy that I did not become faculty until after Jeremy left this fellowship, so I was not included in this. So taking us home for the first session is going to be my co-organizer, Alexandra, who's going to be talking about GLP-1 RAs and eye disease. Thanks so much, Alexandra.
Thanks so much, Kat, and there'll be no embarrassing pictures, I think. All right. So GLP-1 RAs is a hot topic these days, and in US, they're approved for diabetes as well as for obesity. And for diabetes, it's by promoting glucose-dependent insulin release, and in obesity, it is modulating brain-gut signals. And there's been a lot of interest in peer-reviewed publications, and I hear in Florida, everybody is on Ozempic, and it's coming to Cleveland near you as well. So, there's a lot of questions about the effects of these drugs, and we're going to talk about two aspects of this. We're going to talk about diabetic retinopathy, but then we're going to move on from diabetic retinopathy to other eye conditions. So this is a question that's been coming up less and less, actually, but we would get these messages in our electronic medical system asking, this patient is documented to have PDR, should I start them on GLP-1 RA? Or the patients would see direct-to-patient advertisement that would say, it potentially can worsen your eye condition, and they would say, well, I actually stopped the medication. This comes from the warning that's on the semaglutide or Ozempic label that there was more events of diabetic retinopathy complications in patients on that medication. But the argument is not quite clear because potentially GLP-1 RAs could prevent or arrest the development of diabetic retinopathy. Retinal neurodegeneration is an early event in the pathogenesis of DR, and the receptor is expressed in human retina. And there's, as you will see later, there's a lot of work showing that there's neuroprotective effects of GLP-1 RAs on the nervous system. And other clinical trials looking at the other GLP-1 RAs actually didn't reproduce that finding. More importantly, if we think about how these trials are conducted, for those of you who are involved in clinical research, we know how rigorous we are in analysis of diabetic retinopathy, but the assessments were very varied in terms of how it was assessed and who was assessing. The large database studies are also not conclusive and potentially confusing. If we start on the bottom, there was some worsening of DR, but there was significant improvement in glycemic control. And actually, as time went on, DR continued to improve. Other studies showed that there was no association, or the association seemed to be with the improvement in the glycemic control and not necessarily with the drug itself. So we wanted to do an analysis actually on patients at Kola Institute, and to Diana's point, looking at the patients where we can look at the individual data. So we had patients on GLP-1 arrays, and we compared it to patients on SGLT2 inhibitors. And we were very inclusive in our outcomes, clinical worsening by different ICD-10 codes, and also procedural worsening events. And every retinal worsening was evaluated by a retina specialist. So these are our characteristics, and the GLP-1 array users had higher BMI. And of note, also in our population, surprising for Ohio, we had very decent baseline hemoglobin A1C of 8.2, which was lower than in the semaglutide study. Well, we saw that there was no significant difference between GLP-1 arrays and SGLT2 inhibitors when it came to clinical worsening. Importantly, we didn't see any significant change. We didn't see that dramatic drop in glycemic control, probably because our starting hemoglobin A1C was pretty good. So once again, we see no association between GLP-1 arrays and any type of worsening. The question is, why didn't we see this? Well, potentially we had a small sample size, or we had small representation of semaglutide. But I think actually what's happening is that for whatever reason in our cohort, we had a better baseline hemoglobin A1C, and we saw no difference in hemoglobin A1C within and between the groups. And very important, when we first ran the analysis, we saw 126 cases of worsening. But when we looked at each individual case, we saw that it was usually a coding error. So what would happen, for instance, a patient was seen by a general ophthalmologist diagnosed with mild NPDR, sent to Retina, and a retina specialist did an FA and diagnoses them now with severe NPDR. Well, that's a two-step worsening that happened in 2 months. Obviously, it has nothing to do with what the patient has. It's just better imaging modalities. So we have to be very, very careful as we look at the large databases and rely on ICD coding. So when I think about diabetic retinopathy and patients on GLP-1 arrays, I mostly watch patients who have dramatically improving glycemic control, and we've seen it before with insulin. Patients on insulin, they get significantly better, and they have that initial worsening and then stabilization. I think it's important to consider these drugs in DR trials, especially if you're looking at DR changes, because potentially if the groups are not balanced, you might see different outcomes. And prospective studies looking at GLP-1 array effect on DRs are being conducted. So looking at that was resulted in a publication by Julia Ju, who was our medical student and is going to be incoming resident at Kola, and she was the first author in our publication. And then we started thinking more about the effects of GLP-1 arrays on other chronic conditions, and I'm going to talk about age-related macular degeneration. So we talked about how it's approved for diabetes and obesity, but there's been multiple reports showing that there is anti-inflammatory, antioxidant, and anti-apoptotic effects in multiple organ systems. And there's been shown that the effects might be by different mechanisms than those that we see in diabetes. This is just a graph showing that all these different organ systems that are potentially affected, and there's studies looking at semaglutide to treat addiction, Alzheimer's disease, and a slew of other conditions. In fact, this is an interesting publication that just came out this year looking at the VA patient population, and they saw that GLP-1 arrays were associated with reduced risk of substance use, psychotic disorders, seizures, neurodegenerative disorders, and multiple other conditions. So maybe, we all should be taking Ozempic now. And so we wanted to look at the eye, and it's been shown that GLP-1 array are protective against retinal ganglion cell loss in animal models. And our colleagues in glaucoma have shown that it's associated with reduced risk of developing glaucoma after 3 years. So we wanted to look at diseases of aging. And so we did use a large database. Just I told you it has its limitations. But we wanted to be very, very careful in our analysis. So we only included patients who had at least 5 years of ophthalmology follow-up and 5 years of medication documentation. And we compared GLP-1 arrays versus multiple other medications, including metformin, insulin, statins, and aspirin. And we propensity matched our cohorts and looked at different outcomes, such as non-exudative AMD, exudative AMD, POAG, cataract, and ocular hypertension. This is our propensity matching, and we could match on almost everything, but BMI for a metformin group and hemoglobin A1C for metformin group. For insulin comparison, it was just the BMI. What we saw is that GLP-1 arrays tend to reduce the risk of non-exudative AMD after 5 years. We saw it when we compared it to metformin group. We saw it when we compared to insulin group and to all the other medications that we included. Once again, we confirmed what's been seen in glaucoma space, that it seems to reduce the risk of glaucoma at 5 years. And when compared to insulin, we saw this signal for exudative AMD. The question is, how soon does it happen? Well, it appears to happen after 2 to 3 years of use when we look at non-exudative AMD, and similar when we look at exudative AMD compared with insulin. We wanted to do another analysis to make sure we're not seeing some weird trend, and we looked at patients who were older than 70 years of age, and once again we saw the same trend where there's a reduction of non-exudative AMD compared to metformin and insulin. So this study showed that there is potentially reduced risk of non-exudative AMD as well as POAG when we look at GLP-1 arrays compared to metformin, insulin, statins, and aspirin. This reduction appeared after 3 years, and we saw this trend also in exudative AMD when compared to insulin. There was no impact on the risk of cataract formation or ocular hypertension. We talked about the large database, right? It's hard you do rely on ICD-10 coding, and you can't really get granular and look at those patients. And we weren't unable to fully remove confounders with propensity matching as much as we tried. Future direction is prospective trials looking at the effects of these drugs on different stages of AMD. And we also did our internal analysis at COLI looking at the same cohorts. So stay tuned for those presentations. And of course, I want to give a shout out to Kevin Allen, who is a fantastic resident, who is the first author on this paper. And also a big thank you to everybody else who's contributed to this project, including Kat and Rishi on the stage. Thank you so much.
That was a great talk. I think we got so many great talks in the first half of the summit, so thank you to everyone. I know we kind of went through the talk, so if anyone has any questions for any of the panelists on those first few talks, we would love to take them. Yep, I see one hand in the back.
I couldn't hear the whole question. So the question is, how do you know if the effect is the drug or what? So I think it's a great question, right? Is it a direct effect of the class of drugs, or is it secondary to something else, right? And I think it remains to be studied. You know, we did analysis, for instance, looking at retinal vascular diseases like vein occlusion, and I think in that case it's definitely secondary modifications, right? I think in AMD it's interesting because there's been a lot of work done by Dimitris Kondra looking at metformin, and for what it's worth, you know, when we compare it to metformin, GLP-1 arrays did better. So I think it's still, you know, it's very hard to draw concrete conclusions, and also what's the mechanism? Is it the anti-inflammatory mechanism potentially? I think it still remains to be studied, but great question.
Any other questions from the audience? Uh-huh.
Just a question. Any thoughts about what should be the mechanism of skin recognized three different
Do you want to repeat the question?
I think the question was, is there any reason or thought to mechanism for the risk of ischemic optic neuropathy and the complement inhibitors for GA? Christina?
Are you
Christina, do
asking
you mind?
Siri or me? That's a great question. I'm not sure, and please chime in to anyone on the panel. I haven't heard of any sort of plausible explanations for why this could be. I know that complement obviously is involved in multiple aspects of our entire bodies, and so there must be, in one thing I think that it's really interesting is we have to remember that all of these pathways are not occurring in isolation, and when you impact one, you can lead to an imbalance in a different one, right? And I think that's one of the reasons why we see exudative CNVM, although we don't fully understand that either. Does anyone have any thoughts on NAION and its relation?
The only thing I can say about it is that there were 8 cases total in the Oaks and Derby study, 7 of which were in the monthly arm. So the volume is 0.1 cc's, as you're aware, so it might be volume-based. The neuro-ophthalmologist actually looked at the patients, and there was found to also be discs at risk, which unfortunately a lot of our patients have anyway, so I don't think you can use that as an exclusionary factor to determine which patient. In the every other month group, there's only one a report of the whole situation. So
I'll bring up that it's also possible it wasn't AION, it was inflammation, and the nerve was affected by inflammatory changes, and it was maybe something inflammatory and not ischemic. In the cases that were reported in the ASRS series, many of those eyes had nerves that leaked on fluorescein.
And just echo what Tarishi said, when we first saw that, we all wondered if it was the 100 microliter volume problem. But it's, we used to inject 0.1 all the time back in the CMV days. There was never a report of AION. And we, what's that?
Did they get no?
Do they get worked up for, we don't know the answer to that. I'm sure you want to do a research paper on that? You're going to ask to find out.
MRIs for everyone.
Can I ask Rishi a question? Rishi, can you foresee with the multiple pipeline drugs, are we going to get to the point you think that we are treating GA with multiple therapeutics? Like, something that targets one versus another, maybe a systemic therapy and a local?
yeah, it's plausible. I mean, I think, as you know, one of the situations in this is that you could have a reduction in the GA lesion growth, which some of the drugs did show that, but other drugs showed some amount of that transitional zone improvements. So it could be a combination of the two drugs to really affect that. The transitional zone improvements were the ones who actually showed some visual acuity potential benefits. The ones that just slowed GA lesion growth did not show that necessarily. So potentially that would be an opportunity for both drugs to be given together.
Can I make a comment on that?
Go ahead, Dave.
So there's always the possibility that we may wind up doing that. But I think the fundamental issue, there have been 70 clinical trials looking at complement inhibition. 65 of them failed. And of the 5 that worked and one actually didn't meet its primary, so 4, the therapeutic effect is pretty nominal, I think at best. I think we'd all agree with that, which sort of leads to sort of 2 conclusions. One, either complement isn't the entire story, which then if it's not, if we figure that out, then looking at a combination. Or maybe what I think is more likely, we're just intervening too late. And so we spend a lot of time in the network, a lot of time, trying to figure out how to study this disease earlier. And what we need, and Justice alluded to it, we need a good biomarker because they're really, really, really hard trials, long trials, expensive trials to do. I actually think we're just intervening too late, which is one of the biggest problems.
Awesome. I think Ferris, I think you had a question.
For Dr. Martin, any thoughts about arid supplementation for GA? I think there's more evidence about that. If it's as good as complement inhibition.
That was a really, really interesting paper, wasn't it? And the therapeutic effect is about the same size as what we've seen with the 2 complement inhibitors that we have. Granted, over a longer period of time, to be fair. I think it was over 5 years. But I have no idea why, because many of you may recall, so I was part of AREDS. I was one of the authors of AREDS 1 and AREDS 2. And when the initial, and if you read the publication number 8, which was the primary outcome, we included in there that the ARES supplements didn't seem to have much of an effect on GA. And so it's a bit odd that years later we look back at that and go, oh, wait a minute, maybe it did. I'm rambling because I don't know. So is the short answer.
Thank you.
All right, so in the interest of time, we're going to go ahead and take a break now. We're going to have you come back, ask you to come back here, and we're going to restart at 8:35, right? And then we'll postpone our surgical panel to the end. Thank you guys so much, and for the good questions, too.
All right, welcome back to the second part of this meeting. And it's my pleasure to introduce surgeon extraordinaire and my colleague, Dr. Anand Sastry. And he's going to talk about what's new in the retinal surgery platforms. Anand?
Thank you, Alexandra. So these are my financial disclosures. Of note, I am a consultant for Bausch & Lomb as well as Dork, which was recently acquired by Zeiss. And I will be discussing some of their products and technology in this talk. So it's a really exciting time to be a basketball fan as well as a retina surgeon. In both worlds, we're seeing the changing of the guard and the advent of the next generation. We have the Jordan era with the Acurus and the Millennium, followed by the Katie, Stephen, Braun era with the Eva, the Constellation, and the Solaris PC. And now the next phases of the league are here. And what does that mean for us as retina surgeons? It means we get to play with the coolest toys that might allow us to execute tasks and techniques with better precision, ease, and potentially efficiency. So let's get into these newest
Excuse
platforms.
me, where are the WNBA players?
I'm sorry?
WNBA.
Fair enough.
We got Caitlin Clark, Paige Beckers. That's the new generation.
I'll be sure to add them in the next for the next talk. Fair enough. So we respect the W. We respect it. We love the W too. So starting with the most recent, which is the Alcon Unity. So this is Alcon's first combined platform for both retina surgery as well as cataract surgery. And it combines a number of the features from the Constellation and the Centurion, along with a number of critical upgrades, starting with the fluidic system. So we can see here, we have two independent pumps. The top manages the aspiration, the bottom manages the infusion. That, along with the Venturi vacuum, allows you to have vacuum control with high flow that is efficient for core vitrectomy, and it allows you to punch up to 700 millimeters of mercury vacuum to induce PVDs, along with a concurrent precise RB compensation system. On top of that, we now have the ability to have flow control, where you have a constant flow, regardless of what type of material you're engaging with your cutter. So this makes it easy to do vitreous shaving, cut around mobile retina without having the risk of surge and the retina jumping into the cutter. So let's see what this looks like here. So here we're jumping up to 700 millimeters of mercury vacuum with an upper limit of aspiration for the cutter here to induce a PVD. And then here we have flow control where we're able to perform a peripheral vitreous shave, and notice that there's essentially no turbulence in the eye. That lenses are remaining relatively stationary, showing that there's essentially no surge and a constant flow rate. On top of the fluidics, there's new instrumentation that's been developed. There's now a improved 27-gauge cutter with an improved efficiency with 30,000 cuts per minute, as well as improved rigidity, which allows it to approximate a 25-gauge cutter. On top of that, there's the new TetraSpot laser, which allows you to apply up to 4 spots of laser at a time, which improves efficiency for PRP and laser retinopexy. Additionally, there are improved trocar cannulas that allow for better stability, and the most interesting one, which is the unified gas delivery system, which allows for very precise gas dilution. So let's see how that looks. So let's say you choose what concentration you want, say in this case 20% SF6. You rotate the dial, you twist the valve, and the gas gets pulled in. There's an internal filter as well as an external one, and it pulls the exact volume of gas that needs to be done for that dilution. The handle ratchets back and locks so that you don't inadvertently pull out too much or inject before it's been diluted. After you confirm that you have the right concentration, you unlock and then pull the handle all the way back to the very edge of the syringe, and you don't have to think about whether you're going to 50 or 60. It just goes to the fill line, and then you inject your gas, and you don't have to worry about any gas mixing errors. Now here's a video of the TetraSpot laser, and we've got our excellent fellow, Faris, using the TetraSpot laser, which improves efficiency of PRP, not just for fellows, but also for attendings. So this brings us to our next platform, which is the EVA Nexus by Dork. So this too has substantial upgrades in its fluidic system, its software, as well as a new instrumentation suite. So if you take off the cassette, you have a very unique pump system. There's 2 pistons along with a number of valves that manage the flow rate. And this can be titratable to 0.1 cc's per minute and allows for very precise flow in fast vacuum. On top of that, there are a number of sensors in the system that monitor the intraocular pressure. So this allows you to also have vacuum control that is 3 times faster than the traditional Venturi pump, as well as when you go to flow control mode, you don't have that pulsatile surge that you get with the peristaltic pump. So you get better control over mobile retina as well as when you're shaving. On top of that, they have a smart intraocular pressure system that allows you to have either a fixed infusion pressure mode or a fixed intraocular pressure mode. So what's interesting about the fixed IOP mode is that that remains constant while the infusion pressure changes. So this comes into play when you're injecting things like PFO. So what you have here is you're injecting PFO without a dual bore cannula, and as the PFO bubble increases, the system automatically senses it and drops the infusion pressure, and there's no increase in the actual intraocular pressure. So this also allows you then to inject silicone oil without having to use a valve. On top of that, they've improved their trocar cannula, so they've adjusted it to have an MVR blade at the end. They've changed the cannulas to have chamfered edges as well as laser etching. What this is useful for is in long cases where the cannulas want to slip out of the eye over a long period of time. This keeps them in place for longer cases. On top of that, they've adjusted their infusion cannula where it can connect directly to the cannula without having to take off the valved cap. Additionally, they've improved their 2-dimensional cutter to make it stiffer with a better ergonomic handle and increased to 20,000 cuts per minute. And finally, they've developed the Inicio device, which is a subretinal injector for it can be for gene therapy, for TPA, or for fluid if you're doing submacular blebs for chronic macular holes. And so it's connected directly to the device and has its own system that's connected to a foot switch. So here, if you have a submacular hemorrhage, we can inject the TPA into the syringe here. It's connected to the needle, and that needle then plugs in to the device here, which is connected to the machine. And you can choose what pressure you want to inject it at here at 1 psi, and you just press on the foot pedal to inject your TPA. So finally, we get to the last one, which is the Stellaris Elite. This is by Bausch & Lomb. Now, this has come out in 2017, but they are working on their newest platform. But since this one came out, they've had some recent upgrades, including an adaptive fluidic system that also allows for better flow control and allowing to operate at lower intraocular pressures, as well as a higher 25,000 cuts per minute biblade, improved vacuum mode, as well as enhanced light pipe rigidity. We can see here that when you combine the biblade, that's 25,000 cuts per minute, with the adaptive fluidics, you can operate at actually subphysiologic intraocular pressures, which is very helpful for patients who might have severe stage glaucoma or retinal ischemia. And finally, they've developed their own 3D heads-up visualization system called the C-Luma. And what's interesting about this is it has a unique design with a C-arm, which allows you to view the 55-inch 3D 4K screen without having to turn your neck. On top of that, there are digital binoculars that are mounted to the arm, which allows you to see a 3D image even if you're not wearing glasses. And finally, there's an assist mode that's in the software where you can annotate and draw on the screen for teaching. So to summarize, the newest platforms are combined cataract and vitrectomy platforms. We're seeing higher speed cutters than even 20,000 cuts per minute. There's improved vacuum and now flow control. There's the ability to operate safely at lower intraocular pressures. And finally, we will now have multiple options for integration with digital microscopy and heads-up display visualization. Thank you for your attention, and I look forward to any questions.
Thank you, Anand. Next up, we have Sunil Srivastava, who is going to talk about how I usually feel in clinic when I see uveitis patients.
I feel like this too. That's why I'm drinking my second beer. All right, so here are my financial disclosures. And, really, UVS mysteries come down to masquerade syndrome. So I'm just going to tell you that masquerades represent a collection of diseases that can mimic more common diseases. In our world, it's infections and malignancies. And in the setting of chronic immunosuppressive drugs, presentations of common infections can look atypical, so you have to have a high degree of suspicion. So how do you not miss it? Most inflammatory disease that's treated with steroids, you need to follow them closely. You need to avoid long-term therapy, long-term local therapy until infectious causes have been ruled out or a positive response has been seen to oral steroids. And if someone's not responding as anticipated, take a step back and reevaluate. In previous lab results don't match, repeat them, consider a new source of a sample like intraocular, and consider tissue biopsy in settings when the disease is not responding as expected. And if an experienced pathologist or laboratory is not available, send them out to somebody who actually knows how to do this. I always list systemic medications that can cause uveitis, and I think it's really important for all of us to recognize that these medications are a very common cause of uveitis, and if you have an elderly patient who has new onset uveitis, look at their medication list. And I'm going to tell you this list continues to get longer and longer and longer because there are new therapeutics that come out all the time which can have this effect. Keep this high in your differential. Ask your patients, what's new, what's different, what have you started on? So let me show you a case, 32-year-old female, 2-year history of haze and floater, is referred for vitritis despite lots of rounds of steroids, periocular steroids, adalimumab, extensive workup, which is negative 20/20 and 20/60. Here's a look in with a fair amount of vitreous cell in both eyes and a vitreous haze. You can't see the retina really, really well. The OCT is a little enlightening because there is appear to be some cystoid macular edema in the left eye and epiretinal membrane, also known as a fellow emergency in the left eye, something that needs to be addressed yesterday. The fluorescein angiogram really is not really helpful. It just shows diffuse leakage, giving you an idea there's more to what's happening and just what we're seeing, more of the retina is involved. So what do? We have this patient who has had clear pan-uveitis. She's active on adalimumab. It's not clear if she's ever responded. She came from an outside institution. What do? Should we push the systemic medication? Should we treat locally? Should we rework up? In these scenarios, when I get somebody new who comes to me, or we get somebody new who comes to us, we start all over again. So I want to prove that this thing is actually sensitive to steroids. I want to prove it's inflammatory to me because I'm a little bit worried. So we restart the patient on steroids. The vitreous haze gets better, but as we taper off, the patient starts to get worse. And not only do they get a little bit worse, they get a lot worse as we come down off the steroids. And you can see here that the OCT initially improved, but now it's getting worse. So maybe this is inflammatory, but it's really important that you repeat your clinical exam. Because when you repeat the clinical exam in this patient and you look with your slit lamp, you can see this dense sheet of cells, which gives you a hint that something else is going on. So unable to keep inactive unless prednisone dose is high. This looks like something we're biopsying. What am I biopsying and looking for? I'm always worried about malignancy, even in a young person like this. Let's see if it plays. Didn't play. It was phenomenal surgery. We did a great job. So this was biopsy positive for lymphoma in this very, very young patient. This started at age 29, and at 32, she finally gets a diagnosis. So when you look at this, she actually does pretty well. She actually improves. She's 20/40. Unfortunately, develops brain lesions now 3 to 4 years later. So what were the clues of lymphoma? If you went back and looked at it, certainly we showed you the sheets of cells. We showed you the response to steroids that took a little bit of time and didn't really make sense. But if you looked really, really closely at that OCT, if you're going to get the images, there were a couple of clues at the RPE level that told you that something else was going on. It took a little time to look at this, and once you went back and looked at the images, it became a little clearer that the clues were there, but you have to look at it. If we're going to get these images, we have to look at them pretty carefully. So let me show you another case, something that we all see all the time. We get referred patients who have intraretinal fluid. So this began 4 years ago with some conjunctivitis and blurred vision, noted to have intraretinal fluid on an OCT, waxing and waning course, treated with topical steroids, topical NSAIDs, or a combination. Here's the initial presentation. You can see the intraretinal fluid, not a fellow emergency because there's no epiretinal membrane. So we look at this patient and look at the OCT, and it looks like pretty classic petaloid leakage in someone who's phakic. So what do? So this is the patient over time, a presentation, gets treated with a course of steroids and NSAIDs, and over 3 to 4 years, seen by other people, they get a waxing and waning course, and now 3 years and 8 months later, the cystoid edema seems to be getting worse in the right eye, and now is referred for worsening vision, and now has inflammation 4 years later. 2100, where they were 20/30, and 20/30 in the left eye. 2+ cell, and here's the look in the eye. So now there's some vitritis. And on the floor, on the OCT, you can see now there's a significant amount of subretinal fluid that has presented in this patient. So what do we think now? So this patient has now shown us worsening. The fluorescein looks like there's petaloid leakage, but if you look really carefully at the left eye, there seems to be this granular appearance in the periphery that wasn't really picked up before. Does the differential change? Is this new inflammation, or was it the same disease all along? Start all over and rethink your diagnosis. So initially, when the patient was seen, because there was no inflammation, this was the differential. Could it be any one of these things? Now we're going to add inflammation, and now the differential changes. And it turns out this patient is syphilis positive. So this patient gets treated, RPR is 1 in 256, the CSF VDRL is positive, and over time slowly improves, and the vision gets better. So was it syphilis all along? Yeah, probably. Looks like it, just based on what we're seeing 4 years before the diagnosis is made, because if you look at some of these changes that we're seeing, it was kind of clear that some of this was going on initially. The last case I'm going to show you is something that's homage to Dan. Of course, he has incredible timing because he's not in the room. So I have a better because of Dan Martin. This is a 23-year-old male because presents with blurred vision in the right eye for 2 days. Saw an outside provider, was concerned for infection. Started on Valsite, got a serologic workup, referred for additional management. 2300, good timing, my friend. 2300 in the right eye, 2020. He hears his name and he just walks in. That's how it works. I like the crown. Well, 1+ AC cell, and his review systems is negative, but he has a new cat and a new partner. And as I told Jeremy Levine, there's nothing good that comes from new cats. So I'm sorry, this highlighted image, I'm just giving you the mag. You can see the intraretinal hemorrhages. You can see the nerve appears edematous. You can see that there's some sort of vitritis. There's definitely some macular edema as well. Maybe some vascular sheathing as well as we look at this patient. The other eye looks great. Nothing else is going on and exciting. So we got a 23-year-old with vasculitis, retinitis, a new cat, and a new partner. What do we think? Well, I'm going to test this patient for everything because I'm just concerned of what's happening. So this patient gets AC tap and inject foscarnet. We do some labs. I do a review of systems one more time and no oral genital ulcers. Comes back 4 days later. His Bartonella is positive. Everything else is negative. Well, this doesn't really look like Bartonella to me, but we treat him because we have a positive test. And why did I order the test to begin with? I'm not going to treat it. And start him on Bactrim and prednisone. Actually does pretty well. Over 10 days, gets better. Vision improves. He starts to see better. The OCT gets better. Over time, he gets better. And he's to this point where you can see the macular fluid is gone, but you can now see the retinal vascular sheathing that, and the sclerotic vessel that exists. Comes back 2 years later. He's supposed to see Dan, but he was on vacation. 20/30 in the right eye, 2100 in the left eye. So now his left eye is involved. Here's his appearance. Now he has a new area of retinitis in his left eye where he didn't have it before. You can see the macular edema, the cells in the eye in your OCT. You can see the thinning on the OCT in the right eye and the vascular leakage that's occurring in the artery of the left eye. So an arterial vasculitis that's occurring with a history of vasculitis in the other eye that you can see really well here. So I'm going to ask you again. Tell me about your oral ulcers. Now I do it with incredible detail, with an incredibly slow southern accent. I get sores in my mouth often when I eat too much pizza. Tell me about your genital ulcers. First, I describe them with exquisite detail, as Dan Martin would have described. I have a sore on my penis. I'm not sure if it came from my partner biting me, but yes, it was an ulcer. The partner and he had a full body rash 4 months ago, and both are syphilis positive, and they were treated for antibiotics. Well, that doesn't make any sense because this happened a couple of years ago. But it turns out he has oral ulcers, genital ulcers, and vasculitis. His syphilis is positive, but his RPR is negative. This looks like it's Behçet's. Starts him on immune suppression, and he does great over time, and he's 20/30. So I've become better at asking about ulcers, and I'd like to thank Dan, who has taught me a lot about lots of important things. But one of my favorites is that there's an art in asking about genital ulcers. You should learn from me. I may be one of the best in the world about asking about genital ulcers. I am not lying to you. This was a conversation we had and continue to have for 25 years. Yes, he is. So, in summary, not all cases of UBS are inflammatory. Reconsider the diagnosis when things aren't responding. Use our tools to assist in diagnosis. Ask your patients the uncomfortable questions like you are Dan Martin. Thank you very much.
All right, I don't think there'll be any also is in the next talk. It's my pleasure to introduce Kat Talcott talking about IRD updates.
I don't know who scheduled me to talk after you, but I got to make sure that doesn't happen next year. So the most important thing that I need to say as a disclosure is that I am not an IRD specialist. So if you have any questions about IRD, Tom Mandel is sitting in the front row. Thank you very much. So this is going to be just sort of an overview of some of the updates that's in this exciting field. So in terms of IRDs, there's really been a tremendous amount of advance in the understanding of the genetic basis for IRDs. And this makes the IRD feel really poised to have leaps in terms of therapeutic options. Luxturna became the first FDA-approved gene therapy treatment back in 2017. And there are a number of ongoing clinical trials that could lead to additional therapies being approved over the next few years. But sort of our treatment approach for IRDs in general is changing. And rather than just having a one-size-fits-all, we really need a variety of different treatment options for IRDs because patients come to us at different stages of the disease. So early in the disease course, the focus might be to sort of halt or to stop the retina from continuing to get worse. And so pharmacotherapies can modulate the underlying disease as well as look at a genetic basis. But later in the disease course, patients might have already have poor vision. And so there might need to be a different approach. So rather than sort of focusing on getting the gene to sort of work better, you might want to change the approach to focus on actually restoring visual function. And so I'm going to talk a little bit in my talk about other approaches like optogenetics, stem cell therapies, and retinal prostheses that are being investigated for this. So this is really going to be a high-level sort of talk, and I'm not going to include everything that's being developed, and I'm first going to sort of group by disease. So we're going to start off by talking about RP. So MGT-009 is subretinal gene therapy with an AAV vector that's looking at targeting loss of function problems in the RPGR gene. In a phase 1 and 2 trial, this compared subretinal injections of low, intermediate, and high dose in X-linked RP patients. And they found that those in the high dose actually had a decrease in retinal sensitivity and had inflammation, but those in the 2 lower dose cohorts actually had improved retinal sensitivity and functional vision at 1 year. And so based on this, the phase 3 Lumius study is underway. It has enrolled 97 patients. This is just one of the tables from the phase 1-2 study, and this is looking at how patients performed in terms of their walk time under different lighting conditions. And you can see in the low and medium groups that in deep twilight, they actually had significant improvement in terms of walk time compared to untreated patients. AGTC 501 from Beacon is an AAV capsid delivered subretinally as well, and it's also aimed to restore the RPGR gene function. The phase 2 Skyline study included 29 patients, and the first 9 patients were actually treated out in the periphery, first for safety, and then the subsequent patients were then treated centrally. And microperimetry sensitivity actually improved at 1 year for all centrally dosed patients. And so based on this, the phase 2-3 VISTA study is enrolling. This is a study, actually, thank you so much to Alexandra for passing this along, showing the subretinal approach and using intraoperative OCT to really confirm the correct location. It can be really difficult to, engage the potential space in these cases, but intraop OCT can be really helpful as you see that bleb open up. So there's also other things in the RP pipeline. There's BIIB 112 from Biogen, which is another subretinal therapy. In the phase 2-3 Xeria study, it did not meet its primary endpoint, but there were positive trends seen in low luminous visual acuity. So those who were exiting the study were put into the phase 3 Solstice study. From Ocugen, OCU400 is modifier gene therapy product, so a little bit different than some of the other treatments that we talked about. They had a phase 1-2 study of 9 patients that showed improvement in low luminance visual acuity, and so the phase 3 Limelight study is ongoing. And then one of the final ones is from Spare Vision, SPVN06, which is subretinal therapy to express rod-derived cone viable factor. So Stargardt disease, as we know, is an autosomal like recessive macular dystrophy caused by variants in the ABCA4 gene, causing toxic accumulations of vitamin A byproducts. So this was mentioned earlier in the context of GA by Rishi, but gildaretinol is being developed by Alkeus, which is a modified form of vitamin A, which is given as a once daily oral medication, which makes it very attractive, and it's designed to replace our natural vitamin A. So this was looked at in the TEASE study, which looked at 50 patients, and that found that actually gildaretinol slowed the growth rate of atrophic lesions. This sort of demonstrates that a little bit more, so showing the slower growth rate for patients who are treated by gilteritinol. The phase 2 TEASE study actually has 4 different phases looking at patients at different stages of disease for Stargardt. So the TEASE 2 study, which showed patients with moderate disease, where we're hoping to have top-line results in 2025, and TEASE 3, which is looking at early-stage disease. 5 patients have completed 24 months of therapy in this open-label study and had no disease-like progression. Other things in the Stargardt pipeline include avacincaptad pegol, which we've talked about in the first session in the context of GA, as well as from Ocugen, OCU410ST, which is subretinal therapy for RORA. And that's being looked at in a phase 2/3 study after the phase 1/2 Guardian study. So in terms of other indications for X-linked retinoschisis from Adsena, there is ATSN201, which will be examined in the phase 1/2 Lighthouse study. But here are some examples from the cohorts that were seen, and you can see in the patients who were sort of treated that they actually had improvement at the fovea in terms of the retinoschisis, which is impressive. So moving gears, talking about sort of optogenetics and advanced retinal degeneration. So therapies for these advanced patients are really focused on restoring vision rather than trying to slow retinal loss. So, as Alexandra had mentioned, she was involved with earlier, Argus was approved for this indication before, but was discontinued in 2020. And so optogenetics really uses exogenous photosensitive proteins, or opsins, to be able to manipulate neuronal activity in response to light stimulating. So this is really aimed towards making bipolar cells or ganglion cells sensitive to light, so then you can bypass non-functional photoreceptor cells. And this should be able to work for sort of any IRD that causes photoreceptor death if they work. So several companies have started trials for this. MCO10 from Nanoscope targets opsin expression to bipolar cells, and this is the therapy is aimed at creating these cells to be functional at ambient light levels, so that patients don't need any specialized hardware to be able to take advantage of this. So after given via an injection, the bipolar cells should be able to respond to sort of ambient light and allow patients to see. So they had a phase 1/2 clinical trial that included 12 patients with advanced RP and got an injection, and 9 out of those 11 patients actually got an improvement in luminous level improvements. And there's a separate phase 2 Restore study that showed similar improvements. And then another phase 2 study, Starlight, is being investigated for Stargardts with the plan for a phase 3 study. And you can see that there are some of the results from the Restore 2B3 study. GS30 is another therapy, and it's AAV-based gene therapy with the use of light-stimulating goggles, so the patients will need that additional hardware for the treatment of end-stage RP. And that was looked at in the phase 1/2 Pioneer study, where they got a single injection of this, and then patients were trained with the goggles for 8 weeks after the injections, and showed that in the patients with the higher doses, they could have some better functioning in terms of vision. So recruitment is ongoing, and this trial will be a longer one. And then finally, from Bionic Sight, this is a recombinant AAV vector that expresses an enhanced light-sensitive channel like rhodopsin for the treatment of RP. And there's a phase 1/2 dose escalation study that's recruiting 20 patients. But the patients with the highest doses have been better able to identify objects. So there's a number of clinical trials that are really aimed to preserve or restore vision for IRD patients. It's really exploded in the past few years. And I think this really changes the way we approach our IRD patients, and that we should consider testing them for any genetic basis, as well as thinking about these options as we take care of them, because the options for treatment are going to be different depending on their disease, as well as where they are in their disease course. Thank you.
Thanks so much, Kat. Next up, we have Srusi Aripali. She's going to talk about what's new in the treatment of RVO.
Okay. Thanks for having me, and thanks to the organizers for inviting me. So today we're going to be talking a little bit about treatment updates for RVOs. So retinal vein occlusions sometimes feel a little bit like the redheaded stepchild of retina. We have so many trials that look at diabetic macular edema and AMD that we sort of forget about this disease a little bit. But it's a really important disease to consider. It's the second most common cause of retinal vascular disease in our patients, and it's a really frequent cause of vision loss. And when we have a patient who walks in with this disease, we're not only treating them with their acute presentation, so non-perfusion or macular edema, but we're also following them for complications like neovascularization. And on top of that, we need to coordinate their care to mitigate the risk factors that led to this to begin with. Now, currently, we live in an era where we have lots of intravitreal agents that we can reach for, and we're really lucky. They have a nice safety profile and efficacy profile. But before we had these, we actually had really smart surgical and medical retina specialists who worked against the pathology of RVOs to try to see if they could improve the perfusion or target the macular edema. Ways they would do this would be a combination of a vitrectomy with an arteriovenous sheathotomy, so essentially reducing the compression of an artery over a vein. You could directly cannulate a vein, or you could treat a CRVO as a compression or a compartment syndrome and make little radial cuts against the optic nerve in order to improve perfusion. You could also use laser, so you could laser the macula for leaking vessels. You could also try to induce anastomoses between different beds of vasculature. And then the tried and true PPV and ILM peel, like Sunil said, probably was floated by a fellow in order to get better case numbers. Then in 2009, we start to see clinical trials being rolled out looking at our intravitreal agents. So on the next couple of slides, we're going to have a timeline that kind of orients us to the years. On the top, in orange, you're going to see studies that are oriented towards BRVOs. On the bottom, studies that are oriented towards CRVOs. And if you see arrows that are going across, those are extension trials. So essentially, a trial ended, and then we followed them for longer and longer. So in the beginning, we started with intravitreal steroids. We compared them to standard of care, which was grid photocoagulation, or sham, or just observation. And then we started delving into intravitreal bevacizumab, ranibizumab, and aflibercept. We compared them against each other. We compared them to steroids. We compared them to laser. And we compared them versus different dosages of each other. This continues until today. In 2019, there was a really nice study that came out, LEVO, that looked at all three of these against each other. It was a non-inferiority trial, and it showed that all three gave pretty similar results. So it tells us that at this time point, we had three really nice molecules that we could reach for to get the end result we wanted. Fast forwarding a little bit, after these three drugs kind of dominated the market, we then started to see in 2021 biosimilars becoming more available. So for those of us that don't know as much about biosimilars, they're actually molecules that are not an exact copy of the originator molecule. So an originator molecule is bevacizumab, ranibizumab, or aflibercept, but it's a close copy and it achieves the same effect. The approval process for these molecules are also different. Instead of having 2 clinical trials for a certain indication before you get FDA approval, you just need one, and that one trial is usually a non-inferiority trial. So for example, if you have a biosimilar for aflibercept, you have one trial, you show non-inferiority for one of the indications for aflibercept, and then you get to apply it for all of the indications for aflibercept, even if you didn't prove it in your trial. So that opens up a huge basket of new tools and drugs that are available to us. These are just some of the ones that are available, but there's almost 100 available worldwide. Now we have 2 new molecules that we've touched upon earlier today as well that are starting to be studied in RVO and CRVO trials. So we have intravitreal faricizumab, who is a little bit different than our typical anti-VEGF therapies. There's one arm that has an anti-VEGF, but then another arm that targets Ang2. And the thought process here is that perhaps we'll get better efficacy, better effect, or better duration compared to our traditional agents. And that was studied in 2 trials, Balaton and Camino. And then we have aflibercept 8 milligrams. That's a higher dosage than the 2 milligrams, but with the same idea. Perhaps we can get better control or better duration. So I'm going to talk a little bit about these trials in depth. For Balaton and Camino, there's 2 parts to this. The first part goes up to 24 weeks, and then there's an extension or a treat and extend period after the 24 weeks. The paper that just came out is looking at the first 24 weeks, where you use faricimab 6 milligrams every 4 weeks against aflibercept 2 milligrams. We had similar arms for BRVO and CRVO. When we did this, this trial was made to be a non-inferiority trial, so we were able to see that faricimab was non-inferior to aflibercept 2 milligrams by 2 metrics: improvement in best-corrected visual acuity from baseline, but also with reduction in CST. What the authors of these papers also did, what I thought was very interesting, is they looked at fluorescein angiography signals. So they looked to see if there was resolution of macular leakage on fluorescein angiogram when treated with faricimab versus aflibercept. And what they found was that there was a statistically higher proportion of patients who were treated with faricimab who had resolution of their macular edema. In the second part of that trial, they then started to treat and extend patients up to 16 weeks, and initial results have shown that that's promising as well. So it provides us with a medication that perhaps gives us better angiographic results, but also longer duration. And then for aflibercept 8 milligrams, the official results haven't been released yet, but this trial is a little bit different. Instead of comparing to every 4 weeks, which is what all of our trials have done before, they started with 8 milligrams every 8 weeks. While the official paper hasn't been published yet, it has been noted in various presentations this year that the primary endpoint was reached and it's been accepted for priority review with the FDA. This is a lot of information on this slide, but this is essentially a composition of all of the trials that we talked about in the first slides. And for any of these agents that are anti-VEGF, the point of this is to show that generally the improvement from baseline visual acuity is between the 10 to 20 letter range. And we're able to mimic that with our newer agents as well, but the exciting thing is perhaps we can use longer duration as well too. And that shows through in BRVO and CRVO. So our takeaways here are that we have multiple treatment options that are available. We've expanded our repertoire immensely, and now we focus on the improvement in outcomes and duration for the drugs. Thank you.
Thanks so much, Ruthie, and I would like to welcome Anant back. He's going to talk about addressing diabetic tractional retinal detachments.
I thought you were done with me, but alas, you must suffer me for another 8 minutes. So these are my financial disclosures, none of which are relevant this time. So I tell all my fellows that there's no such thing as any easy cases in retina, and this is particularly true for diabetic TRDs, which are some of the most challenging cases that we do. However, I'd like to share with you some of the things that I've learned over a few years of doing this from personal experience, making a lot of mistakes, and of course, picking up a lot of tips and tricks from my colleagues and friends that have shifted my experience from very scary to substantially less scary. So the path to success for any surgery begins in preoperative planning. So with this, the first thing that I always want to look at is making sure that the patient's medical comorbidities are well controlled, particularly hypertension. These are generally very sick patients, even if they don't always look like they are. And the last thing that you need is for the patient to undergo a heart attack or a stroke while they're on your table. Next thing that you want to do is check the examination. You know, we generally try to avoid doing concurrent cataract surgery if we can avoid it. Usually even with 3 to 4 plus NS, you can actually get pretty good visualization. But if there's pretty dense PSC or if there's blood staining the posterior capsule, sometimes you need to do a concurrent cataract surgery. You also always want to check the fellow eye to see if they have concurrent PER in that eye and to see if you might want to consider doing PRP in the OR, oftentimes under general anesthesia for the other eye. And then finally, if you have a good view, you don't always because there's vitreous hemorrhage sometimes, I like to check retinal perfusion with a fluorescein angiogram because if there's macular ischemia, this is very helpful for counseling and visual prognosis. It also gives us some tips and tricks as to how we're going to potentially handle the tissue. And then finally, we want to make sure that there's preoperative anti-VEGF injections that are administered. I generally like to do at least one injection 3 to 7 days prior to surgery, but sometimes if these patients are very vascularized, I might even consider giving them 2 to 3 monthly injections prior to surgery. Now, of course, this leads to the question, what about crunch syndrome? This is a very real thing, but it's not as frequent as one might be led to believe with all the discussions that there are out there. But even if it does happen, I would argue that the case is still easier due to the avascular surgical planes that are obtained by preoperative anti-VEGF and better hemostasis. There's nothing more miserable than having constant oozing during the case. And you can still get pretty excellent visual outcomes. You just have to discuss this with the patient ahead of time. So here's an example of a patient, of a 33-year-old type 1 diabetic who was referred 1 week after getting an anti-VEGF injection for non-clearing vitreous hemorrhage in a TRD. And he crunched so badly that he developed a total TRD-RRD with 2500 vision. And in the case, you can see that the fibrous tissue has fibrosed substantially. There's not a lot of vascularization. It was fairly simple to take care of, and he did great. You know, we post-op month 3 after doing a vitrectomy. He improved to 20/30 vision, and this is what his OCT looked like. So all of this is to illustrate that crunch is not the end of the world. These cases can actually be easier than you think as long as you get avascular surgical planes. So now we go to the operating room, and so now we've done our pre-op anti-VEGF, so what's the first step? It's, of course, separating AP traction here with the circumferential vitrectomy. Now, even with this step, you sometimes have to be careful because sometimes if there's a lot of vitreous hemorrhage, you might not see how elevated the retinal tissue is, and you want to avoid going too deep and inadvertently creating a retinectomy. Additionally, you want to make sure that you're not too superficial and you get adequate separation of AP traction. So I like staining with Kenalog at the beginning here. So now that you've done that, you want to, how do we access the tissue? So I like to go with an inside-out approach, usually attacking the nerve and seeing if we can create space there to start our segmentation. So usually I'll go with forceps, just gently peeling at the nerve. And here it's usually pretty safe to do so. You just do it very gently, trying to lift and create a little bit of space so you can begin your segmentation planes here. And so not pulling too hard. And now we can begin our segmentation now that we've created this space with the cutter here. So a little more on segmentation. So once we get to this part of segmentation, I like to use a high magnification system and use a 27 gauge beveled cutter. I find that the 27 gauge and the bevel allows me to access relatively tight spaces more so than the 25 gauge cutter. And I like to drop my vacuum and my cut rate very, very low so that we get like a scissor type feel with it, and allows it to more efficiently cut the dense tissue. And here we want to engage the tissue and do a little lift and cut so that we can actually see what we're cutting and making sure that we're not engaging retinal tissue inadvertently. So here we're getting some segmentation. I try to stroke it a little bit and kind of tease it, see what the tissue is giving me, and don't want to force the issue if it's not coming. And then try different areas until we find the spots of weakness. Now, at some point, you might find that even with this, it's still too tight. And what happens then? Now, there's some surgeons out there who say that they can do every case with just the 25 gauge cutter. And to those of you who can, I tip my hat. I don't have the surgical skill that you do. And in these situations where it gets just too tight for the cutter to access, I find it very helpful to be able to be facile with other types of instruments. And in my hands, that is the curved horizontal scissors. So here, trying to get something, I can't get anything going. It's just too tight here. And so switching to the curved horizontal scissors, we're able to get access segmentation here. So here we're putting one jaw in and one jaw out and just cutting here, and that's allowing us to access the plane. And what I like about this is that it's got the jaw is very thin. It's even thinner than the 27 gauge cutter. It's blunt tipped, and it allows us to create a nice surgical plane here, and now we can switch over to our cutter and extend the segmentation here. But sometimes even this is not enough, and so when I first started, I tried to see if I could do everything with one hand. As time has passed, I've just decided that I'm going to bite the bullet and just go ahead and throw a chandelier and go in bimanually. You lose nothing by doing this. I find that it's actually saved me a considerable amount of time in many cases where I've been going at it for a very long time and just getting nowhere. And now by switching over to a bimanual technique, using again curved horizontal scissors for scissors delamination, using max grip forceps, you're able to trim at the interface between the retinal tissue and the fibrous tissue. And I just find that it's so much more efficient and easy to get these broad areas of attachment that just simply wouldn't be possible or would just take a very, very long time if you just tried to do this with one hand or with the cutter. And you can see here that we're able to loosen up the tissue here and delaminate these very wide areas of attachment here. So after we do this, one of the things that I've started doing more and more often is staining with some type of dye and trying to peel the ILM. And so the reason I like to do this in TRD cases is that it accomplishes a number of things. Number one, it allows me to ensure that I've removed the hyaloid off of the macular surface, and also sometimes helps me unroof some residual hyaloid and extend the planes further peripherally. It also minimizes the risk of having a postoperative ERM that can happen in these diabetic cases. It also helps, what I find really interesting, it helps decouple the macula from any peripheral traction that might still exist at the areas of the arcades that you might not be able to remove. So you can flatten the macula and not have any traction there at the fovea, even if there's traction more peripherally. Now, the question becomes, how much of this do I need to do? When is enough enough? How much of this hyaloid do I need to remove? I generally find that in cases of TRDs, if I've been able to remove the traction off of the macula and there's no other plaques that I'm worried about potentially contracting or causing recurrent bleeds, I'll generally just leave it, as in this case. However, if you have a traction rhegmatogenous detachment, like in this case, you have to get all of the hyaloid off. You have to remove everything and make sure that the traction is off, particularly at the brakes. If you fail to do this, the retina will not reattach, or you will get the most spectacular PVR redetachments that you've ever seen. Then, of course, once this is all done, you have to do a full treatment with PRP. I always do this from the arcades to the aura, including scleral depression, to make sure that there's no residual ischemia that can occur at the end. And then you finish with your tamponade. Now, what kind of tamponade choice are you going to use? I generally prefer gas in my hands, mildly expansile if possible if I'm using SF6, or isoexpansol if using C3F8. I find that having some gas minimizes the chances of hypotony, particularly if you're doing sutureless or rebleeding. Silicone oil I try to reserve only for monocular patients. I generally don't like to see the membranes and fibrous tissue that can form at the interface between residual blood and oil. So to summarize, I like to consider pre-op anti-VEGF. Use Kenalog early to visualize the vitreous for separating AP traction. Forceps to lift the nerve and to enable an inside-out approach. 27-gauge beveled cutter for segmentation. Curved scissors for delamination and for axis segmentation. ILM peeling to prevent recurrent ERM and to decouple the macula from residual traction. Full PRP and a gas tamponade if preferable. Thanks for your attention.
Thank you, Anant. And I'm going to bring back Diana talking about therapeutics with novel mechanism of action in neovascular AMD.
Great. Well, it's exciting to come back and now switch gears and talk about new therapies for neovascular AMD. My disclosures are noted here. Why are we even looking at new therapies for neovascular AMD? Standard of care anti-VEGF-A injections are very beneficial when dosed appropriately. Christina Wang, do you feel in your hands, do your patients have optimal vision outcomes, or do you think there's a gap?
Oh, my patients have optimal outcomes indeed.
I knew it. I know you're outstanding.
Yeah, but no, you're absolutely right that we've seen many post-hoc analyses and retrospective studies that patients do not even get close to the visual acuity improvements that we see in our standard trials. And a lot of that, not all of it, but a lot of it has to do with the fact that they aren't getting as many injections as they were in those trials.
You are the best, Christina. And that's why we're looking for new therapies. We're trying to bring better outcomes to real-world clinical practice. But there are a lot of drugs in development, but I'm just going to concentrate on tyrosine kinase inhibitors, which are currently in phase 3 clinical trials. What are TKIs? They are small molecules that act intracellularly, so different than the typical anti-VEGF agents that act on the extracellular matrix. And they try to inhibit all the VEGF 1, 2, and 3 receptors through an intracellular route. Let's first look at EYP-1901, which is in phase 3 clinical trials. This is vorolanib, and it selectively inhibits all the VEGF signaling by blocking through intracellular routes. It's delivered via an intra-office injection, a bioerodible implant. And the phase 2 DAVIO studies had promising results, which led to now the phase 3 clinical trials. In this clinical trial, the EYP-1901 was compared against aflibercept 2 milligrams. And what the investigators saw was that there was a reduction in the treatment burden. But we did see that more than 50% of patients did need rescue therapy. But the good news was there were no safety signals, and that's why a phase 3 study looking at 2.7 milligrams of EYP-1901 is being tested head-to-head against aflibercept 2 milligrams. And hopefully we'll have some of these results later this year. Another tyrosine kinase inhibitor that is also actively in phase 3 clinical trials is OTX-TKI. This is axitinib in hydrogel, also delivered via an intravitreal in-office injection designed to have sustained delivery of VEGF suppression. A phase 1 clinical trial in the United States showed that this drug did reduce the treatment burden in these patients who had a high need for VEGF suppression. Furthermore, there were no safety signals. The SOL-1 study finished enrollment, and a SOL-R study is ongoing. And hopefully in the near future, we'll have clinical trial data on that. We're also looking at tyrosine kinase inhibitors in the suprachoroidal space, and this was done via a suprachoroidal injection of axitinib. And the phase 2b Odyssey study results were recently released, and this also showed positive durability looking at week 36 outcomes. In this clinical trial, visual acuity was stable throughout the follow-up period with stable and anatomic outcomes, and 67% of participants did not require any supplemental treatment for up to 24 weeks. They are hopefully planning a phase 3 clinical trial. So tyrosine kinase inhibitors are now near the brink of possible FDA approval. But all these clinical trials did not test tyrosine kinase inhibitors alone. Most of them required upfront anti-VEGF injections, such as aflibercept, and then a treatment with a tyrosine kinase inhibitor. I want to ask Rishi Singh, what do you think about this new clinical paradigm where we're starting with an anti-VEGF therapy agent and then possibly adding a tyrosine kinase inhibitor? Is it attractive to you? What do you think are the challenges with this new approach?
Yeah, durability is what we're always challenged with. And certainly, this is an opportunity. I think your point is well taken. And I think the short-term data, like the 6-month data, isn't really worth looking at because of the loading period you talked about. Many of our patients, if they got 1 or 2 injections potentially, would have been continually not needing injections at 6 months. But it's really at the 1 year, 2-year endpoints that we're going to see some degradation potentially.
Great, so we're going to look forward to more long-term data. Now let's review something that recently came up in our news as well. We are very excited about VEGF-C and D inhibition, and in fact, 2 global clinical trials were conducted looking at sozinibercept, which is a VEGF-C and D inhibitor that was tested in eyes with treatment-naive wet AMD. And the interesting thing was the phase 3 COAST clinical trial top-line data was recently presented. And it showed that, unfortunately, sozinibercept, given in combination with aflibercept, did not meet its primary endpoint. That is, there was no difference in the visual acuity outcomes, and it behaved very similarly to monotherapy with aflibercept 2 milligrams. What can we learn from these clinical trials? What's useful and what are key lessons when clinical trials do not always go as planned? Well, we have to remember that actually 90% of drug development actually fails. And in Retina, we were very comfortable with seeing successes, but in reality, most of the times, drugs don't make it across the finish line. And the common reasons for failure include lack of efficacy, which we saw in the COAST clinical trials. There could be safety issues, there could be pharmacokinetic properties, there could also be lack of commercial interest. What I wanted to ask maybe our clinical trial expert, Dr. Dan Martin here, is how do we de-risk clinical trials going forward? A lot of us are key opinion leaders, looking at drug development. What is your strategy, Dan?
Wow, I can fill the rest of your time with that one.
30 seconds, bro.
30 seconds.
Thanks, I appreciate it. I'm going to have to keep going. This is a much longer discussion that we talk about, again, all the time in the network. The problem is that with the FDA sort of, when Wiley left, we were left with some very challenging scenarios. We're pretty much going to have to do superiority trials at this point. I'm going to pass on the question because I have a number of answers, but it'll take me 10 minutes to do it.
Great. Well, I wanted to leave you with this last slide because I think it's a challenge for all of us to consider. Innovation is still amazing in Retina, but there are challenges, and hopefully we can collaborate together to de-risk clinical trials in the future. Thank you.
I will say, I think one of the real problems we had, so it was fascinating that the Opthea trials didn't work. And I think the real question is, have we reached the ceiling in terms of how much visual acuity benefit can be achieved with anti-VEGF? I personally think we have. If you think about it, there's no randomized clinical trial that has ever shown a visual acuity difference between any 2 drugs. Avastin was equal to Lucentis. Lucentis was equal to Lucentis. Lucentis was compared against in view 1, view 2. They were equivalent or non-inferior. Then Eylea became the standard for comparison. So in the Hawk and Harrier, there was no difference. In Tenaya Lucerne, there was no difference. I mean, there's never been a visual acuity difference in any of the anti-VEGF drugs. None. The only difference is durability, dosing and durability. And I personally think we've kind of reached a ceiling in terms of how much visual acuity improvement you're going to see. This is why I said it was going to take a long time to do this. Sorry. And so the question is, how do you de-risk those clinical trials? You de-risk it by changing the questions that you ask. But unfortunately, the agency has put all of pharma in a very difficult position because, in essence, they have to show a 15-letter difference now. And that's almost impossible to do against the anti-VEGF drugs that we have. So there's other ways. You have to redefine your primary outcome and ask the questions differently.
Great comment, and we're going to have you come to the podium and talk about the RCR update. Thanks, Dan.
Great. Wow, this thing's pretty short. Okay. Anyway, thank you. Each year I give an update on the DRCR Retina network. I have no conflict of interest to disclose. So I always open with this slide. The network, just for everyone knows the network, but just to remind you. So in 2002, it was created as the Diabetic Retinopathy Clinical Research Network. I had the privilege of being one of the founders of this group, and then I left it for a while to do CAT, and then when I came back in 2017 as the network chair for when it expanded, and we decided it was too big of a job, so we created 2 network chairs. So Jennifer Sun is my partner, who's fantastic and wonderful to work with. We now study all retinal diseases. Jenny mostly does diabetes. I mostly do everything else, but the truth is we work so well together that we kind of all do all of it. We renamed ourselves the DRCR Retina Network, and we've to date performed 40 multi-center trials, 141 publications, and at 141 sites and 120 publications. And many of these trials are ones that you all know: Protocol T, Protocol I, S, V, W, AB. By the way, I'll mention in AB, we mentioned crunch. I totally agree with what Anand said. One of the things we were really worried about, so protocol AB was 205 patients with vitreous hemorrhage, proliferative diabetic retinopathy, randomly assigned to anti-VEGF injections, a sequence of 6 injections of aflibercept versus primary vitrectomy. And one of the things we were really concerned about was, would we see crunch in that setting? We didn't. It happens a lot less, but it's a real thing. It does happen. I totally agree with you. You'd rather operate on those eyes under anti-VEGF control, so to speak, than without. So we're currently running more clinical trials than we ever have in our history. This is a list of the trials that are either ongoing. AP, we're actually probably going to start at the end of this month. And I'm not going to cover all these. I'm just going to cover the highlights. By the way, I am the warm-up act for Christina. I'm going to reverse the alphabet here and just mention AO at the end, and then Christina's going to give the complete AO presentation. So protocol AF, Jeremy alluded to this one. It's a randomized trial evaluating fenofibrate for the prevention of diabetic retinopathy worsening. As he has already shown you, both in the Accord Eye and the field study, there was pretty good data that suggests use of fenofibrate reduced the progression rates, 3-step or 2-step progression rate in the DRSS. And then the LENS study came along and also had a similar finding. So we're optimistic what we're going to see here. The trial design is 560 patients randomly assigned to fenofibrate versus placebo. The primary outcome is at 4 years. And we are getting very close to finishing the enrollment on this. And we think that by the end of this year, perhaps the beginning of next year, we will complete the enrollment. But then we've got to follow these patients. So we're still looking at probably a 2029 or later presentation of the primary results. Another reason why this trial's really evolved into something even more than what we had thought, because so many things have changed in the diabetic retinopathy world, specifically the GLP-1 receptor agonist and also continuous glucose monitoring, the insulin pumps. There's a lot of speculation as to has the natural history of change of diabetic retinopathy. And it's one of the things that we've prospectively defined how we're going to look at it and hope to be able to provide a lot of data to answer the question, are we studying the same disease as we were 20 years ago? I'll skip briefly through this one, Protocol AI. We actually have we have 9 ongoing studies. And we're really perfectly set up to do this because we have 43,000 images, and it's not the images that are missing in most AI efforts. It's the phenotype. It's just like in a GWAS. There's no shortage of genetic material. It is how well developed is the phenotype upon which you're using to separate out these groups. And here you have probably the best characterized group of patients on the planet. Protocol AL. This was, Arun Singh approached me with this idea. It started as a tiny little trial, and it grew into something much larger. It is anti-VEGF versus sustained-release steroids for the prevention of radiation retinopathy. This is the trial design. 600 eyes, that's a tough ask. And we'll see if we get there. In large part because the ocular melanoma community is not, last time they did a randomized clinical trial was COMS 35 years ago. And so this is not something that they're used to doing, but this has been a blast to design this trial. It's so much fun designing this thing. It's basically eyes that are at risk for radiation retinopathy. Those are eyes that receive more than 30 gray, and the tumor can't be under the geometric center of the fovea or can't touch the nerve because those are two going to get torched probably with the radiation. Randomly assigned to faricimab, Iluvien, or observation. Primary outcomes at 3 years. We're also going to have the opportunity to develop a radiation retinopathy score, just like we did with DRSS, and look at how the vasculature changes to how much progressive ischemia takes place. Protocol AM is a randomized trial comparing immediate versus deferred surgery. So we all have these patients that come in that have 450 microns of central subfield thickness and loss of foveal architecture. You have a convex fovea, and they're 20/25. What do you do with that? So the question is, if you defer, but they're symptomatic, if you defer that surgery, and you ultimately operate on them 3 years later, have you compromised their long-term visual outcome? That's the question we're trying to get to. This is a hard study to enroll. It's also we're about halfway there. It's 400 eyes. We're over 200 now. It's been slow to enroll because, as it turns out, here's a little clue. All those 20/40 eyes that you think you're operating on, and we get this 450 microns of central subfield thickness, and the fellow's like, salivating because, oh God, here's a pucker, right? So turns out if you do ETDR protocol refraction, most eyes are not 20/40, they're probably 20/25. We're operating on a lot of 20/25 eyes now. We just don't know it because we're using our crappy Snellen and visual acuity in our retina clinics, right? This done usually very quickly. So that is just a reality check. So we've had to alter our entry criteria to even be able to enroll this study. Protocol AP is one that we think was going to start at the end of this month, or certainly by June. 3 years trying to arrive at what was the right protocol. Everybody wanted us to look at combination therapy. Once we published Protocol S, which was the anti-VEGF ranibizumab for a PDR, and we all tried that, and then we had a lot of these eyes progress because these patients disappear, and they come back and they progress. So the idea is most of us do combination therapy at this point. So the question is, how does that compare with doing a primary vitrectomy? The problem with both faricimab, with anti-VEGF injections and laser, is you're not dealing with a hyaloid. And at the end of the day, after you've done your first PRP, if you still get recurrent hemorrhages, it ain't the ischemia, it's the hyaloid that's the problem. And so this is a chance to look at, will one and done take care of these patients? It's 426 eyes randomly assigned to immediate vitrectomy and laser versus faricimab. And the final, I said on the setup for my colleague Christina Wang, is homo-CT guided treatment versus treat and extend for neovascular AMD. This is my favorite trial that we've put together. It's enrolling like gangbusters, and Christina's going to tell you more about that. So we got lots of new studies that are coming. If any of you are out there interested and involved with the network, please do. We need you. This group's been around for 23 years. I've had the incredible privilege to serve in a leadership role now for 8 years, and it's just a wonderful group to work with. There's a lot of academic opportunity for those of you out there who are about to begin your career. Thank you.
Thank you, Dan. And we're going to bring Christina back to talk about Home OCT.
Thanks, Alexandra. Thank you for that awesome overview, Dan. And I want to echo what he said to the fellows in the room. Participating in the network has been super rewarding. It's a great way to cut your teeth if you're interested in participating in clinical trials, and it really is sort of an open forum type of thing where you can actually sign up. You don't have to be invited. Just go onto the website. You can talk to Dan, myself, or any of us involved. We'd love to have you. Super excited to close off here talking about Home OCT, which is a technology that I'm very optimistic will potentially transform the way that we manage one of our most common diseases. Here are my disclosures. I do serve as the protocol chair of Protocol AO through the DRCR Retina Network, but other than that, I want to emphasize that I don't have any financial disclosures in relation to Notel Vision, who is the manufacturer of this device. This is an artificial intelligence supported device that allows patients to self-capture high-resolution OCT scans from the comfort of their own home. Super cool technology. And Notel Vision does so much more than just manufacture this machine. It really also serves a really important role in providing data analytics, which is really the key point of this type of technology. So up at the top, let me orient you. These are the types of B scans that you're getting from patients who are scanning their eyes daily in that machine. You can see they're very high resolution. They look very similar to the OCTs that we get in our clinics on a daily basis. 3 by 3 millimeter scans, so slightly smaller than what you might be used to, but you can see great detail, 88 B scans stacked 34 microns apart, so excellent resolution. The most important thing to take away that I want to emphasize is in the second row, which is, again, this is an AI-supported platform. And so you are not going to be reading OCTs every day as they come through. The AI proprietary platform is doing the heavy lifting, and it also provides these wonderful spatial fluid maps so you can get a quick idea on FOS of where that fluid is. My favorite type of data analytic is what you see in the bottom row, which are these fluid volume trajectories, where each day that the patient scans is a point on the x-axis, and on the y-axis is the fluid that is present, volumetric data in nanoliters. And so this is taking a little bit of a mental shift to volumetric thinking in 3 dimensions instead of how we currently refer to fluid in 2 dimensions on our OCT. And that really is progressive because we see lots of data coming out that that's more informative and prognostic potentially for telling us information about how that patient's going to do. Now, the original impetus in development of the Home OCT really was to facilitate earlier detection of the conversion of patients between dry to the wet form of macular degeneration. We know that the earlier you catch somebody, the earlier you can treat them, and the better their visual prognosis will be. And we know that from a lot of studies, including this large IRIS database study of nearly 163,000 eyes, where they took patients that were newly diagnosed with wet macular degeneration. And the bottom line is they stratified them by their baseline visual acuity, as you can see there on the left, and followed them as they received treatment over the course of 2 years. The main takeaway that I want to highlight from this particular figure is that while in general, pretty much all the patients either improved or stabilized in terms of visual acuity, you can see that most of them stayed within their swim lanes, right? So those who started off with better vision ended up with better vision at 2 years, and vice versa with those who started with worse vision, even though they were all receiving very effective therapy. Really just emphasizing the point that early diagnosis before vision is adversely affected is really important. But can we use this technology now to patients who are already diagnosed with wet macular degeneration? That's the question we're going to be looking at. And I'll draw your attention to really start at a basic level, which is to look at the current treatment schedules that we use, right? 3 schedules that are used around the world to treat wet macular degeneration. All of these have pros and cons, but far and away the most common utilized amongst American retina specialists is treat and extend in the middle, which aims to maximize visual acuity outcomes while minimizing treatment and visit burden. But with that said, treat and extend also has its drawbacks, as it tends to overtreat some patients and undertreat others. And so this buzzword of personalized medicine is floating, ubiquitously these days, right? So I ask you, why aren't we using something like PRN, which is much more personalized, more customized, instead of something like Treat and Extend, which 90% of us are doing? And the more I thought about it, it really comes down to this. It's because we don't currently have the ability to assess how patients are doing in between their office visits. But of course, that could change with the emergence of home OCT. Let me show you 2 examples of patients. Here's an example of a patient with wet macular degeneration who is receiving Q6-week injections. I want you to just focus on the B scans at the top. You can see a little sliver of subretinal fluid highlighted in green there, and they look very similar between the 6-week interval, right? So if you looked at just those OCT scans, which is our current situation, you might wonder to yourself, is this patient even responding to the drug that I'm giving them? And it's not until you have the luxury of that fluid volume trajectory at the bottom that you learn a couple of really important things. Number one, that the patient indeed responds very well to the drug. You can see they nadir pretty much immediately after the injection is given, but they probably just need that interval contracted a little bit to like 4.5 or 5 weeks instead, right? So that's something that we've learned, and this is an example of a patient who might currently be undertreated with Treat and Extend regimens that we use. In contrast, take a look at this patient who was diagnosed and treated for the first time in November of 2022 and immediately nadired and was at 0 nanoliters of fluid until about the 12-week point. So they immediately extended to 12 weeks before the fluid recurred and then was brought back for another treatment. Do you know how long it takes to get to Q12 on a Treat and Extend regimen? So I just did this for curiosity when I was making these slides. It takes about 44 weeks to reach that, even if you extend straight through and they never have a drop of fluid. And so this is a great example of a patient who's currently potentially overtreated on our Treat and Extend regimens. And this is a great demonstration of how home OCT can support faster extension, and that might be particularly valuable in light of these longer durability therapeutics that Diana just really beautifully covered, like our TKIs and gene therapy. A lot of potential applications there. Now, the value of a home monitoring device like this really hinges on accuracy and feasibility. And fortunately, there have been several small studies that have already confirmed both of these aspects, showing that indeed the home OCT is very accurate in its detection of fluid, and also, and probably equally if not more importantly, easily utilized by this demographic of patients in their 70s, 80s, and 90s. Most of them are able to acquire these images in less than 45 seconds. And so really, I think it's prime time, and the stage is set right now for a large-scale prospective study to ask this question whether home OCT can be used to really revolutionize the way that we manage our wet AMD and really take us one step closer to true personalized medicine. And hence, DRCR Retina Network Protocol AO in the alphabet soup. We're in double letters now. Soon we're going to be in triple letters. I don't know what we're going to do then, Dan. But you can remember this one because of OCT. And this is really the brainchild of a brilliant retina specialist. Not many people have heard of him before. He's not very well known, but really the brainchild of Dan Martin, and it really has truly been a pleasure working on this trial with you, Dan, from development through execution now. 10,000-foot view, this is a multi-center randomized clinical trial. 600 eyes will be randomized. These 600 eyes, by the way, are treatment-naive wet AMD eyes, so newly diagnosed treatment-naive wet AMD eyes. 1-to-1, they'll be randomized into either a Treat and Extend regimen or home OCT-guided treatment regimen. All eyes will receive faricimab in this study, and the co-primary outcomes that we're looking at are going to be the mean change in visual acuity and the number of injections from baseline through 2 years. It's a 2-year study. I'm thrilled to share that we just crossed the halfway point in recruitment recently. I'm very impatient, so can't be fast enough, but we're getting there, and really has had great uptake in the community. So in summary, home OCT might not only allow for earlier detection of conversion to wet AMD, but might also be able to have its applications pushed even further. This device has been FDA cleared as of spring of last year. It's not yet commercially available. That's one of the benefits of patients who are participating in the study. There's lots of questions that float around in my mind. I'm not ignorant to these, that we have to think about things like integration into workflow, reimbursement, applications to potentially other diseases. But we're going to find out those answers and more in the many studies that are ongoing, including DRCR Protocol AO, and a shameless plug that if you have any treatment-naive wet AMD patients, to send them to your nearest participating site, including the Cleveland Clinic. So thank you very much, you guys. Appreciate it.
Fantastic talks, and we'll move on to Q&A. Any questions from the audience? Anand?
I have a question for Christina. Great talk. The biggest concern I have with this is logging into my chart and seeing 500 messages and phone calls of patients saying, "Doc, I checked my OCT today and the day before and the day before, and today it's like a little different than it was the day before." And how do you foresee this playing out, and how would you manage that?
It's a great question. I love Dan's input in this too, Nant, but it is definitely something that we think about, and it is going to, any type of paradigm shift is going to require reassessing and potential adjustments in our workflow. The first thing I'll say is that currently as it stands, the patients don't see the images or get any reports, and they don't even know if they've alerted. So we set an alert threshold, and when they cross that threshold, the alerts come directly to whoever you want to designate, but right now it comes to the investigator and the lead study coordinator. And we will then contact the patient and let them know, hey, you've alerted, and arrange for them to come into the office for an in-office evaluation. I don't know if that might change down the line. We've had discussions about that, but that's how the system actually stands at this point. But that's a very valid issue, that when you have maybe 1,000 patients on home OCT, you're going to have some of those alert, right? And those emails are going to come through to us, and we're going to have to find a way to manage them. But I'm confident that our field has been able to really be very nimble, and we're able to adjust if we think something is worthwhile for our patients and to improve care. Anything to add, Dan?
Perfectly answered. Yeah, the reason, this is exactly why they don't see it. Because it turns out, once you see what's going on between your injections, I can't imagine not knowing this information. It turns out, not infrequently, you get little blips of five nanoliters. You get the RPE desiccates the subretinal space. It does its job, and unbeknownst to all of us, it's not uncommon for patients to have little blips that are there one day and gone the next, and that's not noise. So it's. And I don't want to get those phone calls from people who say, oh, it went up, this little bit. They're not going to understand what's meaningful and what's not. So that's probably the number one reason why they're not seeing those images right now. The burden so far, I think, on our clinical practices has been pretty low.
It really has. I was really worried about that, honestly, because we're juggling this with our usual volume of patients. And I will say it's been pretty seamless. Now, that being said, we don't have hundreds and thousands of patients right now per physician, but I will say that once you have a workflow in place, who's going to call the patient, who's going to check in the portal, who's going to make the appointment, et cetera, it flows like any other workflow in our clinics, at least so far.
And supposedly you're going to get paid to do this, so we still know how much that's going to be.
Christina,
the monthly review.
Right.
Christina, one of the things that you highlighted that I think is potentially tremendously advantageous is the idea of going to rapid extension with this. We're going to learn a tremendous amount from this study. We know now from numerous trials that the volatility issue has potential negative consequences. And so what we don't know is what's the level of volatility threshold if we go to PRN with home OCT that leads to that, and what's the delay in getting them in to see us once they hit that threshold. And so for me, regardless of all of that, if I was able to actually treat them to dry and then just watch them at least just once until they get to 12 weeks or 16 weeks, the impact on our practices would be incredible. So I think regardless of the PRN or not PRN, that aspect of being able to tailor it that much quicker, I think is huge.
Justice, I love that point, and it's not even just for rapid extension, which I think the example I showed really hopefully drives that home on how much more of an accelerated path we can take for patients. But I also think in light of sort of these longer durability products, I'm involved with several of the gene therapy candidate development pipelines right now, just monitoring patients and how they do. And one thing that's been fascinating to me is how uncomfortable we get once we talk about letting a patient go more than 12 or 16 weeks without being seen in our clinics. People start, we wish for durability every day, but then when we talk about, hey, a patient might be able to go 6 months, are you comfortable with that? People are like, oh, no, we want to bring them into the clinic just to check, right? This would, I think, give us a lot more confidence for those settings as well.
One of the things, if I had to pick my favorite thing in CAT, 67 publications, the thing that I probably have dwelled on the most is the distribution of the number of injections over a 2-year period. It's absolutely fascinating. You would have thought, we all thought, I thought, going into this that you would see some sort of bell-shaped curve. You don't. It's completely flat. The highest per single percentage for any frequency was only 8%. It's flat. I mean, you have the same frequency of people who need 24 injections as need 2. And so what are we doing? We're superimposing this very coarse, non-granular sort of, we're making up these algorithms like treat and extend. They don't make any sense when you begin to understand the disease. So it is, I hope this all works. We're coming off pretty much in favor of it, but already the information that's been gleaned, at least what we've seen in Protocol AK, and some of the earlier stuff is awfully encouraging. It's hard to imagine how this is not going to impact how we treat patients.
Great. Any other questions, Ferris?
Just a quick question, but I think we touched on a lot of points. So the idea is to treat PRN, but is there maybe consideration that you diagnose someone with neovascular AMD, you do a first injection, then you monitor them, let's say they manifest at 8 weeks or at 12 weeks, and then that's their interval. You take back the machine and then you inject them every 12 weeks.
So can I answer that?
Yeah, please.
So this is like one of the biggest fallacies that exist out there. Neovascular tissue changes over time. It's irrational to think, it's a great question, by the way, not your question. It's irrational to think that it wouldn't. And so as it changes, some vessels become sclerotic and don't leak. Other vessels become mature and leak constantly. And you see that in CAT. We saw it. You look again, the frequency, the number of needed injections. You have 5% who needed 1 injection, and you have 5% who needed 24. And so it's this idea that not only that you're going to find an interval and that's the interval for life is not true, because the vessels are going to continue to evolve. The drugs last about most people wind up about every 8 weeks, but it turns out part of it is because we get locked into it. We just keep doing fixed dosing. For the record, I almost always get people to dry and do PRN first, because 14% of people will only need 3 injections in the first year. And to Christina's point, by the time you get to the point where you do 3 12-week injections, you're out at a year and a half. You've just given that patient 15, you've given 1 in 7 patients 15 months of injections that they didn't need. I promise you start looking for it, you're going to find it. And I don't want to be one of those patients. So I think this is going to help us even tailor that even more.
Fantastic, and a great discussion. So I'm gonna close this session, and I would like to extend my thanks to all our amazing faculty. Thank you for coming and sharing your wisdom with us. I would like to thank the AV team and the Ivista team for everything they have done. I particularly would like to acknowledge all our sponsors. This meeting wouldn't be possible without your support, so thank you so much. And I would like to thank all of you for being here and participating. I know for the East Coast, it's way past the bedtime. At least I feel it is. So thank you, and we hope to see all of you next year. Thank you so much.
Oh, yeah.